meeting of the Board for Public Health Wales. Bore da croeso I gyfarfod Bwrdd Iechyd Cyhoeddus. I'm just going to read the bit that we have to read at the beginning of all the meetings. So this meeting is going to be conducted entirely online and in this room 3.7. Can I ask everybody to speak clearly and say their name and role before they speak, which I didn't. So my name is Claire Jenkins and I am the Vice Chair of the Board and I am chairing today's meeting in Pippa's absence. The meeting of the board is being recorded via Microsoft Teams for the purpose of ensuring an accurate record of the minutes. This recording will be stored until the minutes are confirmed at the next meeting on the 29th of January, after which they'll be deleted. We have some apologies for today, so most notably Britain is unavailable, and some NED colleagues, Catherine, Kate, are unavailable. Samina, our Executive Director of Policy, and Claire Birchall, Executive Director of Nursing, are not here. But we do have in attendance Rebecca Masters for Samina, Angela Cook for Claire, Hugh Williams, Head of EPRR for item 3.6, David Rees and Rosie Dow, Head of Arts and Wellbeing for the Arts Council for item 4, Tom Fowler, Deputy Director of HPSS for item 5, and welcome to Isabel, our graduate trainee, who's here to observe as well. So on that note, can I just check that we don't have any declarations of interest not otherwise noted anywhere? No, lovely, thank you very much. And so on to item 3, the Chief Executive's report.
Diolch Claire, bore da pawb, just for Chief Executive. So quite a long report with, as ever, some great stuff happening across the organisation that just touches the surface to showcase. So, in the interest of time, I'm just going to highlight a couple of areas, and I'm sure colleagues can come in and answer any questions. So, first item was just to update the board around what we've termed the policy advocacy and pre-election engagement. So, firstly, a really big thanks to Samina, to Leo Wargent and Louisa Petchley and many other colleagues who been working with us as a board and colleagues across the organisation to develop 5 really clear policy advocacy messages and areas that we believe pose the most significant opportunities for transforming health in Wales. And I've listed what those are: the best start in life, financial well-being, healthy lives start in our everyday places, care tailored to local need, and a healthy planet. So the team have been working to produce those themes in various products that are in short and sweet. So a short summary of them together with detailed interventions that go with them, and there's a big web presence for people. So they've gone far and wide in their dissemination. And in addition, Pippa, Samina, myself, just minus Claire, have met with, apart from the Greens Party, we've met with all opposition parties, with the imprimatur of the Cabinet Secretary, and they've all been actually very constructive meetings to help them get to know who we are, what we do, but also these messages that we hope can influence manifestos and any future programme for government. So lots happening in that space and really important for us given the election this year. Second point I just want to draw attention to item 2. Structured assessments are a bit like Christmas. They happen every year, perhaps not quite as pleasant or joyous. But I just wanted to flag, and a really big thanks to Paul, to Liz and to Claire and the team right across the organisation, that it's quite a significant achievement to have no new recommendations in a structured assessment report of an organisation with 260 million. And big thanks to Ange and colleagues as well. So important for us to recognise that. The third point is a huge shout out to the achievements of our microbiology infection division and our screening division in relation to all of our laboratory services across Public Health Wales. One of the controls assurance that we have for our laboratories is ISO accreditation, and every now and again they change the standards, which are a significant challenge for the team to then get on top of. And so just really proud that across all of our laboratories we achieved ISO accreditation. Obviously they identified areas for improvement, but nothing significant. So that's a great achievement, and I think a really strong assurance for the board without external controls. So the next point I just want to draw attention to is item 5, which is the health impact assessment. And as the board has been informed and briefed over the last couple of years, Wales is the first country in the UK, in fact, probably mostly of the world, to pass regulations for health impact assessment, which require every public body to undertake a health impact assessment for significant and strategic decisions, and we will not be exempt from that. We obviously have a well-established and internationally recognised health impact assessment unit led by Liz Green, great team sitting in Samina's directorate, and so Liz and the team have worked very closely with Welsh Government colleagues to advise on the regulations, and most importantly, our function being around providing guidance. Can't get my words out today. Guidance, resource, and tools. So a lot of work has gone on with that, and we've recently published a suite of guides. I think importantly for us as an organisation is how we undertake HIAs ourselves for significant decisions. And so I suggest that Rebecca, if we can through you work through what's a good time for maybe as a board development session in advance of them being enacted in April 27. So really positive, but something for us to reflect on. Next item I wanted just to refer to is item 7, which just refers to a pretty groundbreaking report, Do You See My Trauma? The Lived Realities of Minority Ethnic People in Wales, and our Adverse Childhood Experience Support Hub in collaboration with Ethnic Minorities and Youth Support Team Wales East launched this report recently, which just captures a very strong voice and messages of different people as they have experienced tragically, often in many circumstances, traumatic events within communities in Wales, and sharing and surfacing what those are. And there's some really strong, powerful messages. There's an animation as well, but also recommendations as to what we really need to do to tackle that, which is well overdue. And so we'll be reflecting in our interactions with Public Health Wales on that report as well. And then the final couple of points is item 10, update on the public inquiry. We have on the agenda today some details, positioning for our reflections as Public Health Wales on the module 2 A, B and C report, which is about government decision making. So that'd be useful to discuss. But just to highlight the list of upcoming reports of modules and the ones that are more relevant to us. I mean, all of them are, but there are some that are more particularly relevant. Module 3, healthcare system, which is scheduled to be published the 19th of March. Module 4, vaccines and therapeutics, 16th of April. And then the care sector, module 6, and test, trace and isolate, module 7, towards the end of 2026. So as ever, we'll be surfacing it with our teams across the organisation, and just letting people know it's coming through, and we'll be bringing reflections back to the board. And then the final point, sorry, big report, is the final item, which is just a really huge congratulations to Caroline Whitaker being awarded an MBE, the New Year's Honours. Many of the board will know Caroline, who retired last year. A really instrumental member of our team, of Claire's team, who is our former professional leave in nursing, midwifery and standards manager, a real character, and also done a huge amount for veterans and armed forces. So very deserving, and we're very proud of and for Caroline. So I'll stop at that. Thank you.
Lovely. Thank you, Tracy. Does anybody have any questions or comments on the acceptance report? No. There we are. Well, I'd just like to concur with you that we have so much to be proud of from that report. So there's I think we should be very proud of our staff. So 3.2 then, moving on to latest public health overview, and to Ian and to Meng to present. So I think Ian, to kick off.
Yeah, thank you very much. So I'll provide an overview. First off, board members will have noticed that the referral to treatment time area part of the pack was not there. We had a problem with the pipeline coming through from Welsh Government's website, which meant it is inaccurate. We're currently working on it. There is a revised section in there that it needs needs to be brought up to date now following the correction to the referral to treatment statistics. They were, as many of you may be aware, Betsy Cavallador Health Board had an issue with the quality of their data, which was investigated and being revised. The overall picture is of declining referral to treatment time statistics and also declines in people waiting over 1 year. And looking at it particularly, it's ophthalmology where the declines are coming down in it. In terms of other areas I want to highlight, I'll now turn to the wider determinants part of it. And I think there are a couple of things going on which I think are important, not for immediate public health concerns, but potential for future. Particularly across the UK, there is a cooling in the labour market with fewer vacancies, declining levels of employees, and also slight worrying signs around unemployment as well. It's very early, but it's UK-wide, and so we just need to make sure that we keep an eye on that. And also real-time pay growth also was gone negative for the first time in a while. I'll now go to my usual story on the indicators on mental health and well-being and healthy behaviours, where broadly the indicators remain roughly flat in the short term, although longer-term trends are positive in smoking. We're still getting underneath the vaping side of it. The final part I actually want to turn to is actually on the communicable disease aspects, where actually vaccinations this year amongst staff are higher across all health boards in Wales. We still have challenges around the wider population vaccination levels, but even flu and COVID seem a bit better and higher levels this year. I think the final part, though, is actually that C. difficile and in particular is showing sustained reductions across nearly every health board now, which for a while was actually quite a worrying position. Myself and mine, we think it's sustained effort across the system, but we can't at this point in time point to anything in particular because, aha, it was that. Gram death is a bit, it's kind of got the one swallow doesn't make a summer. There's a good indicator for the latest data point, but we need to keep an eye on it. And it may also be linked to the wider trends on antimicrobial resistance, which continue to be positive. So actually, in terms of how Tamsin's usual question around it, which I am due to come back in March on, I think my nuance to it is actually we've got different pictures and different headwinds in different areas, with some of the headwinds and wider determinants maybe not as positive at the moment, but some of the things on communicable diseases actually moving in the right direction. There is actually the point that just because they're moving in the right direction doesn't actually mean it's caused of anything we've done, and evaluation remains important. And we'll come on to it in the IPPR, but we did actually put specifically to try to wrap in actually a lot more about actually the measurement system and moving it to where it should be, what's the latest outcome, and then what are we doing about it and what are the evaluations telling us about the impact of it. So we need to look at that and happy to take questions.
Any questions to Ian on that part? No, lovely. Okay, I think we're move on to you, Meg, if you don't mind.
Thank you. So just want to add to what Ian said about C. diff rates. I think it's the constant raising awareness about the importance of good antimicrobial stewardship, I think, has led to the continued decline. I mean, this is part of a national action plan to reduce healthcare associated infections and antimicrobial resistance, which is a global endeavor. So it's good to see those trends. I think on vaccination, we're continuing to work with our health boards who are predominantly the vaccinators to improve the uptake rates for MMR programs, childhood immunization programs. And you can imagine with the addition of programs of vaccination such as chickenpox earlier this month, it becomes more and more complicated. So the support that our program team does and gives to both Welsh Government and also our providers really helps identify gaps, address health inequalities, and we share evidence to then support professionals in undertaking those roles. I also want to take the opportunity in this section to update on the ongoing incident in relation to the withdrawal of formula milk from the market by Nestle, and then more recently the known Aptamil is also implicated as a product that might cause harm. And this is in relation to a toxin called cereulide, which is a product of Bacillus cereus, which is a bacteria that can infect individuals and cause significant gastrointestinal illness. Because it's in formula milk, it's been implicated in the report of nausea and vomiting and diarrhea in several children across the UK, including potentially 3 infants in Wales. The age ranges from very young, a few weeks to 15 months. So it's a very vulnerable population, clearly. And so we've sent briefing notes out to stakeholders, including health boards working the front line, to look out for such cases to then inform us. And where necessary, we undertake additional investigations to confirm or otherwise the link to this product. But these products have been withdrawn from the market very effectively, so there shouldn't be any continuing threat to public health. However, this is a manufacturing process and there may be implications for other products as well over time.
Any questions or comments from anybody in relation to that? Oh. Okay, lovely. Anything else from you, Meg, at this stage? No? Brilliant. In that case, if we can move on to 3.3 integrated performance report and month nine finance report. And for this, we go to Angela. Thanks, Angela.
Thanks, Chair. Angela Williams doing Bordar. I think it's still, yeah, just about Bordar. Interim Exec Director of Operations and Finance. I've never mastered that one in Welsh, sorry. So, yeah, good morning, everyone. We will now take you through the 3 reports under section 3.3. I will try and guide you through the month 9 integrated performance report, which is in the pack. It's the second attachment. All the other details will hang off this. We normally read this in conjunction with our performance assurance dashboard as well, so there's extra information for colleagues to drill down if they need to. As normal, the report is in 4 sections, with in-focus sections in the report providing additional information where we see challenges in performance or where we are not seeing the improvement needed as per our actions to address that. So I'll kick off with section 1, which is our governance and accountability section. And we'll move through this one together, and I'll ask colleagues to come in to add further information and assurance to what's within the report. So the first section is our people governance section. That starts on page 5 of the 61 pages. And we have 2 in-focus sections, one on sickness absence, which is covered in pages 7 and 8. And one on appraisals and development reviews, which is on page 9, which adds quite a lot of detailed information in there. But Neil, is there anything that you'd like to add to the in-focus sections or any of the other charts within your section?
Yeah, Ange, Neil Lewis, Director of People and OD. Just a couple of areas, if I can. So in terms of sickness absence, we'll see a modest reduction there in terms of numbers, but just wanted to just highlight 2 areas for board as well. So obviously we have had the recent internal audit into well-being and mental health related absence. We had reasonable assurance from that. Some minor points have been picked up primarily around consistency, around kind of managers' practices, and the potential for a centralised repository for documents. But let's say a reasonable assurance there. Some things for us to look into, but nothing significant from that in the piece to report. We did also have a deep dive at the recent People OD committee around sickness absence as well, and got into a lot of detail on that. This has obviously been an ongoing discussion, and we continue to do a lot of proactive work in that space to look to reduce the numbers and obviously make sure we've got the necessary and the right support across the organisation for our people. So that's a kind of constant piece of work for us, as you will appreciate. And then just in terms of agency spend, you'll see obviously that is an absolute key focus for us in line with the Cabinet Secretary's enabling actions. We have seen reductions there. I'm pleased to report we are in target for 25-26 as well. And then just finally in terms of appraisal, which as Angela's highlighted is in focus there. Nothing too significant for report. We obviously have seen a little dip in December there. But certainly in terms of that 85% target, we've been consistently in and around in that area, but we continue to really push that across the organisation as well, given the value that adds. So yeah, just a couple of points there for me. I'm more than happy to pick up any questions.
Thank you, Neil. Anybody have any questions on that? Something?
It's just on the appraisal, stats are good, but I think it maybe went for hot. Just what's our kind of feedback loop? What's our mechanism around appraisals? So kind of what learning we take from the appraisals. So, you know, the figure of our achievement in doing them is often shared, but I'm kind of interested in what sits beneath it and what we learn.
Yeah, that's a really good question. So in terms of what we do, we do a number of kind of deep dives into that tangent as well. We can bring that back to a People OD committee meeting as well, just to look at the quality, the value, to make sure that the conversations that are taking place are really having the desired effect. So that is something that the team do dip into in terms of making sure that is having the desired impact there. There are some areas for improvement that we've identified. Obviously, you're absolutely right to highlight that one of the key themes for us is about making sure those conversations take place and those quality conversations take place. But as I say, we do dive into that just to make sure that quality is there as well.
If I may, Neil, it's also in the staff survey. I can't remember what the figures are, but we should have something we can say, share with the board and Podcom about actually. I think you asked around how did it help you improve your performance and make you feel more motivated or something like that. So there's stuff we can go out and have a look at from there.
And we do triangulate all that data as well, in terms of all the different data sources we have. Obviously, we've got the staff survey, but also a kind of cultural survey as well. Our cultural advocates feed into that as well as our staff networks, trade unions. So in terms of that triangulation of data, lots there. Obviously, we do group that together to make sure we can really drive forward the right behaviours and make sure that and in the areas where we know we need to improve, that we can do some really focused work there.
Just on the agency, just for clarity on that one, because there's a couple of targets for us. So we've got one target which is tracking against the 1.7%, which is last year's amount for us. So we have to show that we demonstrated an improved agency, reduction spend. We've also got the CAPSEC enabling priority around showing a 30% reduction on agency. And we've also got one which is zero admin and clerical. So just for boards to be aware, we'll hit the one which is delivering under 1.17%, which is what we're forecasting. We'll hit the one which is a 30% reduction, but we won't hit the one which is admin and clerical, but we will be working through why that is, because all of our staff, majority of our staff are classed as admin and clerical, where we provide, so a lot of digital, which we, it's just to make that point.
I'll come in and say it's basically not, but often we cut using admin and clerical for anything which genuinely comes under that heavy territory. But we do, particularly in gaps in staffing for critical projects, we will often use agency staff in order to make sure we hit deliverables as well alongside it. Those are in technical roles around data engineering and cloud engineering rather than on things like program management or project management.
It's, I think it's really important that we get on top of this classification. We've been talking about it for a while, haven't we? Because admin and clerical for us, you know, what you've just described, those are not admin and clerical, and it's quite a broad heading. So I think we just need to interpret our classification. I'm not talking about filling the books at all. I'm talking about being really clear that for some things we've got specialist core resources and roles that are needed. So I think we just classify it and we know what's in and what's out. I think that's, and then, you know, to whatever challenge somebody wants to throw, but we've already decided that there's a lot of roles that aren't. So it's probably worth us just tracking that through maybe.
I was just mindful because of the accountability session that it's in there, so it's, you know, sort of, it's in there as I read.
Okay, but we need to take it offline about how we explain that and put maybe break it down a bit, I think. Nick?
I totally agree with that. And I think there is a thing as well about whether we're able to differentiate. One of the challenges around agencies when we're filling gaps that we have because we haven't got people in, as opposed to bringing in a set of expertise that we don't want to carry.
Yeah.
It's a special piece of work where it doesn't make sense for us to own that expertise. And I think particularly in the digital space, that's commonly a reason why you bring people in. It's not because you're trying to replace someone who may be sick or you haven't recruited. It's because specific expertise, as an organisation, we don't need that as a substantive, but we do need them to get projects delivered and over the line.
And you're saying it's also international health, isn't it?
I mean, it's often things, particularly when we've been embryonic, it's been helpful to get an agency in to help us understand, and that's shaped what we need for the future as well. So it's kind of a multitude of things which come in under that. I totally agree.
And we will absolutely pick that up as an action, because I think the whole definition, if you like, and that subjective field around administrative and clerical is kind of applied very differently in the public health Wales context. So it might be helpful, and I'm thinking for us just to kind of split that before, absolutely. So we'll do that.
So moving on to the next section, which is the financial governance. That's on page 10 of the 61 pages. And there is a detailed finance report to support the three charts, which are our three statutory targets that we track. So on a positive, I'll start with the public sector payment policy. So really good progress. It's been tracking green and it's still on track to deliver that for year end as well. So that's the easy one to cover off. The month 9 revenue position, really positive. Small surplus at month 9, 69,000. We carry on with our detailed monitoring. Tracy and I held meetings with each directorate. So we've gone through everybody's forecasts for Q4 and we have assurance, you know, that everyone's on track now to deliver the break-even position, working quite closely with Meg, as you would expect, you know, with the significant budget within HBSS. But loads of, you know, working closely with the directorate on managing the risks and opportunities that we've got around that position as well. From a capital perspective, just some highlights, because things have moved on from the report that's attached, because it's a very fluid position as we go into Q4. So we've got a £3.1 million strategic capital allocation, and we've got a £1.6 million discretionary. We've provided a lot of detail in the report, the finance report, to show how each of those schemes is tracking in Q4. And there is more, you know, progress has happened in January. So it's quite, you know, sort of moving week by week. So a lot of the schemes that we were saying would be, you know, have delivered in January. So I'm providing the assurance to the capital monitoring group that things are on track. And on the strategic one, the largest amount for us there is the £1.4 million linked to the DHPP, from which Ian's leading on, and we've got assurance from the programme that everything's on track there. The milestones will be tracking and delivered by the Q4 deadline as well. The balance sheet is in section 4 of the report, and there's no immediate, sort of concerns or issues to flag on our balance sheet down there. So hopefully that gives board assurance that everything is going as planned for this financial year. Just pause.
I just want on the capital.
Yeah.
One of my favourite subjects. Just when you look at the graph, and you see that we go up above our endpoint and then we come back down again. Just want to help us understand that.
Okay, we just get to the graph.
It's on page 10, as you said. Yeah.
On page 10, yeah.
Yeah.
In terms of
The actual spend, if you look at round about August, I think,
yeah,
the actual spend line goes up, but then it comes back down again a couple of months later. Trying to think how you unspend money.
that's so
That's the big one of the answer. I just want to make sure.
yeah. So you're focusing on the dotted red line, yeah?
Yes, I am.
That was our original plan. So that was the plan spend based on the capital programme or the capital scheme. So we basically were planning to spend more, but then we pushed spend forward in some cases. So that would be how we would be moving, sort of the plan of the programme. Is that?
All right, okay, I assumed that was a fixed plan and I was trying to think how we all spend. All right, okay, it was a moving one.
Many people explain that.
Yeah.
Okay, it looked like we planned to spend something and somehow unspend it.
Yeah, no, it's a positive thing, that we've instead of the spend happening in Q4, we managed to bring schemes forward.
Because if there is a way to unspend it.
And reflect a kind of
Positive. It's positive. That's
all.
Yes.
It's an interesting technique that maybe my accountant would like to know.
I could always share for you.
Don't worry, all the wares are listening.
Okay, any other question? Moving on to the corporate and information and governance. This starts at page 11. And I know there's no in the focus, but I'll just pause to see if Paul, if you wanted to flag anything on any of these slides, because the majority of them sit within your area.
Thanks, Angela. Yes, Paul Vasey, Board Secretary. There's quite a detailed breakdown within the IPR this month around policies, which are looking at a relatively healthy position. But I would draw attention down to the audit summary on page 15, where we've got a summary of our audit tracker activities and the audits that are currently going through or have gone through our Audit and Corporate Governance Committee, which contains some quite useful and positive information there for assurance on how well we're doing in those areas. Other than that, I'm happy to take any questions.
Okay, so moving to clinical governance, quality, safety and improvement. So that starts on page 18. We've got one in focus section, and Angela, I'll turn to you to see if there's anything you wanted to draw to the board's attention.
Thank you very much. Angela Cook, Assistant Director of Nursing and Quality, covering for Claire Birchall today. Just to note that we've had sustained performance in subject access requests and freedom of information handling. We've had an increase in personal data breach activity, particularly related to email handling, and it remains an area of continued focus and improvement work. We've had one early warning, which represents reported in this month, which relates to safeguarding and governance concerns and patient safety. And there's an active IMT ongoing at the moment with that. Our complaints acknowledgement has been delayed in some areas, and again, it's an area that we're trying to improve on. Just to note that the overall incident reporting closure performance remains stable, and we've been targeting this as an area for some months now, as board are aware, and we are seeing some improvements, and we have currently 38 open incidents, which is a big improvement on a few months ago. Those are the bits that I would like to highlight, and just to draw your attention to the riddles as well. Both relate to strips and falls for staff, and we had one incident which was related to an unintended dose of radiation because our Breast Test Wales service was unaware that the participant was under the care of a health board. So thank you. Happy to take questions.
Any questions? Tracy?
It's just to recognise, thanks, Angela, to you and Meng's team. Whilst we should be closing incidents very quickly, we did accumulate quite a significant backlog over the last couple of years, and so it's taken a lot of work to get that down in numbers. So just to recognise that, and a lot of work from everybody, and it's just obviously every now and again there'll be an incident that takes longer to close off, but it's now that we're back down to much more acceptable levels, it's how we can keep that sustained. So just a thank you.
Thank you.
Nick?
I was going to support that entirely. I agree. It's something we've spoken about before, so to see it is really good. Two questions. One was on incidents again, and I don't know whether it's anything to worry about, but there's a lot of volatility around the number of incidents reporting. And I wondered whether it's anything to run about, that the last 2 months ago, it's a very high number. So it comes down again. If you look over the year, it does seem to bounce up and down. And that may be because the number of incidents, but usually in a large organisation, it's a relatively stable line. This seems quite volatile. So intrigued by that. And then the one other actually you've covered, which was about the response to complaints, because it's been very good actually at 100% to see that drop. But you're obviously already looking at that. So it's incidents, whether it is anything to worry about, or you think that might be a natural rhythm.
We've done a lot of work over the last 12 months in encouraging an open culture of reporting.
Yeah.
Particularly sort of with every new starter now, we do an introduction to incident reporting and really encouraging that. And we've done a lot of bespoke work in teams as well. So I think it's a good sign of people actually having that ability to feel confident to report and raising concerns. A lot of them are sort of low harm, no harm events, but they're just a way of sort of raising them and closing them down quickly. So no, I'm not concerned about the number that are coming through. And as Tracy said, we obviously look at every incident and make sure there's an appropriate management plan and oversight in place. And also, sorry.
So just to clarify, it's not about the number. My concern is more about just coming down sharply. So as you would say, I'm more worried about the fact it's like 25% bigger than that drop over the last 2 months, if I'm looking at it over Christmas.
I think I was going to say it's seasonal variation, I would say, over the Christmas period, where a lot of services are, I've got a lot of staff annual leave, but I can certainly take it away and look at if there was any particular areas, but I'm not aware of any that have stood out and been flagged. Because obviously we look at the data every week in our safety huddles, which we look at all incidents that are open at the moment.
Okay, yes, it's about that level of variation, and if it's normal, that's fine, but it just seems to got a bit volatile, that's all.
I don't put my statistician hat on. It is. If you look at it, there is only one data point outside the normal variation type thing, which is 2 months ago. And to my mind, it's pretty much bang on the mean again, where you've got back to. So
See if you say the same next one.
yeah. Well, that's quite the
I
thing.
can't
Yeah. Yeah, one swallow doesn't make a summer.
You'll never have a summer in that one. No, thank you. Helpful.
Onwards. Okay. No more questions on section 1 then, so we move to section 2, which is our service delivery section. So if we start on page 24 for 61, with health protection and screening services, quite a lot of detail already in the in focus sections for Breast Test Wales, bowel screening and diabetic eye screening. So I'll turn to Meg to see if there's anything you want to add over and above what's in those sections.
Yeah, apologies for not introducing myself earlier. Meng Dewey, cyfarwydd with o'r Cenedlaeth o'r Gwasanaethau Diwylliannol Iechyd as Screening National Director for Health Protection and Screening Services. So the focus continues to be on bowel, breast, and diabetic eye screening. And the screening division recognizes that many of these metrics not improve over many months, if not years. Some of the challenge go back to the pause in screening programs during the COVID pandemic, but all have fully recovered technically. However, there are areas of improvement that we actually need to focus on. And the screening division has committed to improvement plans for each of these three key areas. And the detailed plans are aligned to governance processes to monitor and ensure delivery. And these actions, range from workforce development, service delivery and capacity management, quality assurance and governance, regional collaboration, research, innovation, action, and ongoing performance monitoring and management. And for specific programs such as the bowel screening program, where we've had detailed conversations led by Tracy with the exec team in health boards, we've agreed with them a range of lessons that we've learned. We've shared that back with them. We're asking them for their improvement commitments, as well as making commitments of our own. So one of the specifics around bowel cancer screening is the JAG accreditation, which is required for screening colonoscopists, is quite a long process. So we're looking at how we might shorten that, working with health boards. So hopefully that will bring more colonoscopies into the system, because actually what's creating the 4 week delay is the lack of trained and accredited colonoscopists. So that work's ongoing, and you can see from the metrics for bowel screening wait times that the colonoscopy waits are actually improving. I mean, it's a modest improvement, but they're improving. We're taking measures also to consider taking back funding for underactivity. So that's going to be put into the agreements for next year, beginning the 1st of April. And payments will be made quarterly instead of at the beginning of the year. So hopefully those measures will improve the metrics over time, but we've got degrees of confidence for each of the actions that we're taking built into those improvement plans that we can certainly share with the board, who will be wanting to know the detail behind them. Breast Test Wales also has committed to an improvement plan, and the board will be aware of the review that we've taken on Breast Test Wales, and that review is reaching its conclusion and will be reporting back to BET in early March for a full discussion about how we put in place measures to do systemic changes, which is what's needed for Breast Test Wales. The metrics around the 3-week assessment wait haven't improved, and in fact have deteriorated. And some of it is related to specific issues in North Wales that we are working with them to mitigate. But there continues to be a backlog of women waiting for their assessment clinics, which is not acceptable. The team recognizes that. Some of it is easier to fix than others, which require long-term specialist workforce development and planning in order to get the people we need in the right places. So there is an element of mutual aid across the 3 regions to support North Wales, but ultimately the ideal is that we have the necessary clinical capacity locally within North Wales, both in terms of radiographers and also surgeons to deal with cases that come through for referrals. So that's ongoing work, and there's more we can do around bringing the 3 regions together to have collective processes that are consistent. And the work that we've done around the ionizing radiation regulations that were subject to an HIW improvement notice have now corrected, and actually the all Wales approach to that has been really beneficial, so that we've got a consistent single approach to all three regions. We're applying the learning as we go along from all that we do across the programs to inform the implementation of a lung cancer screening program. So the incident relating to the mobile units that board is aware of. We have actually put in place measures to ensure that the procurement of our lung cancer infrastructure is cognizant of the learning that we've had from those units. And then lastly, on diabetic eye screening, again, an improvement program and plan is in place. And I think this is where there is some hope in some innovation around the use of eye drops, which is conventionally used to make sure that the pupil is dilated to an extent where you can capture a really good quality image on which to grade the severity of any retinopathy that's present. However, with the new cameras that we have, the images are such good quality that we feel that routinely we might not need to put eye drops. And eye drops actually cause delay in the flow of clinics and also has an impact on individuals. So it means that they can't drive to the clinics because they have to wait many hours before they can drive again. So often people are accompanied or they have to rely on public transport. So that work's ongoing. The evaluation of that is planned for later this year. So once we have assurance that it is safe to carry out this, we will introduce that into our clinics, and that will improve capacity for all our clinics to be able to screen more people in a certain session. I've also been told that we are accommodating for people who do not attend for their appointments by having a reserve list for every session that we have, so that at short notice we can call people in to have their screen should there be a DNA. So I'm confident that the team are working on solutions, but ultimately for programs like the diabetic eye screening program, we have to ask whether the resource envelope that we have is sufficient because of the increase. So there's some modeling work ongoing to understand whether or not we've actually reached that resource capacity. Because what we're trying to do is prioritizing the new referrals, because these are probably the most at risk. We don't know what the risks are. So we're prioritizing them to have screens early on. But the knock-on effect is that then we have to delay those that we are routinely screening either on a 2-yearly or annual basis. So I'll stop there, but very happy to go into detail on any of them.
Tracy? Yeah, thanks, Meng, and I think there's a lot going on around improvement plans. I think at some point it would be helpful to share those with board members for assurance. And I think and you and I are having so many conversations about it, I think it's who does what by when. I think that's what we absolutely need. And with the improvement trajectories, I think bowel screening is a challenge on improvement trajectories, and whilst we are delivering on our part of the pathway, we're overperforming on our part of the pathway, in fact. At the front end, it's very difficult to drag health boards without being in the organisations, and they're in very, very challenging times. So, but nevertheless, I think we probably need to see the improvement plans. If we can chase health boards to send those in to us and agree an improvement trajectory as part of those, maybe let them know we want to see that. I think that's what we put forward, is the improvement trajectories that each health board is putting forward, to see how we can then aggregate that into improvement of the national service. So I think for a board perspective, if we could share the improvement plans, and you and I will be meeting with Sharon to go through them, and the specifics about timelines, I think that's really important. What are we doing by when, and then let's put the improvement trajectories, start to put them in the IPR, because then we can hold each other to account. I think that's the thing. Notwithstanding that, we need to put a lot of support into screening at the moment as well.
Sharon, did you want to come in?
Thank you. Yes, good morning. Sian Griffiths, Non-Executive Director. I just, actually building on what you've just said, Tracy, one of the things I was wondering about was how much we'd quantified the impact on the population of the pathway not performing to practice, and the pathway being both us and health boards. So what is the additional morbidity from not detecting the cancers early, or the additional mortality from not detecting the cancers early? Have we expressed the harm to the population in these terms, just so we understand why it's so important to get these pathways acting at optimum process? Do we have that data? Do we have that data, Meng? Do we know what the impact of us not performing, if we were to say we were to achieve our goal and the number of people we'd screened was at the level that we want it to be, how many lives would that have altered in terms of decreased morbidity, decreased mortality? Do we understand the data in those terms? Impact outcome data.
So we can work back to the assumptions of screening programs based on the evidence, and we can calculate that. So it's probably a question of prioritizing and maybe working with Ian's team to see if we can assess that for each, if that would be of interest to the board.
I think it's the board and the health board's discussion needs to be about the impact of the screening programs. Why are we doing it? And if they're suboptimal, what's the impact? I think that's partly what I'm trying to raise here. So I think it would be of interest to know what the epidemiology and the data looks like over the longer period for the whole program, because what we do is part of the pathway of care rather than the, it's good to look at what we do, but how does it fit into the overall health of the population?
Ian, did you want to respond on this?
Yeah, I'll come in on this particularly. I think there's a bit of work we're doing for Meng to look at the overall impact of screening, which is part of the remit letter. That's work underway. What we'll need to do is accelerate some of that and look into it with the particular. As Meng says, though, some of this is, how can you put it? You've got to do it from a modelling perspective here, because it's perspective rather than actually happened. So quite happy to work with Meng as well to put some of the modelling team in order to do it. And also with seeing Rebecca sitting opposite me, we might want to create an economic impact on that as well.
Thank you.
Catherine?
I think two questions. One, mentioned the resource envelope for the diabetic eye screening. Is that not possibly the case across all screening? I mean, is there an issue of resource, and are we actively recruiting? Because when I read the breast screening, it seems as though there's an issue around staffing again and again and again. And I think the similar thing with the colonoscopy is, I was going to ask, who is in charge of changing the standards? So you mentioned changing the standards of who is eligible to do the procedure. Who leads on that? Who is that a Welsh agreement, or is that is there kind of standards across the UK?
So a few things to unpack there. In terms of demand across all our screening programs, I think the increased demand from newly diagnosed diabetes is probably more prominent in terms of testing. For the others, they are bound by age or gender, so they're easier to predict, and we're not seeing huge demographic shifts that gives us concern about an increasing call. However, there are some programs like Breast Test Wales where the uptake currently is 69.2% of women who take up their appointments within 6 months of the offer. That can rise with currently the interest around breast cancer screening. That could rise, and so the demand would maybe rise in relation to campaigns, and some of that might just tip us over the balance in terms of capacity. So we have raised that with Welsh Government as a potential area of concern should the current campaigns, which might have a very short-term impact on uptake. The issue around specialist workforce capacity in Breast Test Wales is a real one. We rely on surgeons, which will be a health board role, but also radiographers and radiologists, and that's the bottleneck currently in North Wales. And this isn't an overnight fix, so the recruitment drives are ongoing to see if anyone wants to come and work in that program, but they've not been successful. So some of it is about working with HEIW on the pipeline. We have an imaging academy. They're putting out lots of radiographers, radiologists into the system. But if people don't want to come and work in North Wales, that's an issue. So I think this is where the innovative practice comes in, making sure that we provide a safe service. So remote reading of images is something that we've put in place as part of the surge, but that has an impact on the host team because there's still the day job for them. So the surge that they have provided to North Wales has largely been out of their normal hours through additional hours, such as a waiting list initiative. So that's not sustainable. What would really help is if we have an attractive offer for people to come and work in North Wales. And this is not just about radiographers and radiologists. We have this issue for microbiologists as well, and recruitment campaigns fail to attract. So it's an ongoing issue. We're trying to recruit, and we are working on the pipeline so that people understand that that's an option to provide that service in North Wales.
And the colonoscopy?
So the colonoscopy and the JAG accreditation is set by the UK National Screening Committee. So those standards are what we comply with. It's not so much changing those standards because we wouldn't want to do them because they're quite stringent and robust, and I think provides safe practice for screening colonoscopy. Because actually screening colonoscopy, although the technique is similar to routine colonoscopies for diagnostic referrals, the vigilance and the thresholds in which they need to spot very small lesions is very different for screening colonoscopies. So we need that stringent accreditation process. What is in our gift, however, is through a quality assurance lens, think about the process that could be quicker. So currently it takes 2 years, typically. We want to try and shorten it to a year. And some of it's about the process of making sure that there's allocated time for the assessments. Currently it's ad hoc, but if we were to build in like an exam, it happens twice a year, then that might just accelerate some of the processes. Now, if you take an approach that puts people through for assessment much quicker, like they have in England, the failure rate is higher. So I think there's a trade-off about what we can do safely in order to ensure that we get the outcome, which is more JAG accredited colonoscopies.
Yeah, I mean, it's a difficult one because every service is challenged at the moment across health systems. I guess 2 parts. On the DESU, I was around, not long started when the service transferred in from Cardiff and Vale, and we were in a bit of a dispute with Welsh Government about there wasn't enough money when it transferred. There was no funding around quality, so we've been on the back foot all the way through. And with the increasing prevalence going up like that, then we really need to be tackling that. However, I think the challenge for us is when we have persistent poor performance, you've really got to step back and diversify the model. And so, for particularly DESU, what does that look like? Can we do some pilots around we've had this conversation about, how advanced is technology for people to do retinal scans? Does that help trigger filter? It may not. What's the relationship with optometrists? We can do enhanced payments through a whole organised high street service, which triages through all the way through to quite radically changing the service model. And I think that's the challenge that we should be really proposing ourselves rather than doing a similar thing and just tweaking the edges. And the thing similar with BTW, we're just not and haven't been able to recruit. So in a modern day world with remote imaging, what does a clinically governed service look like with more insourcing of remote interpretation? That doesn't solve all, because we do need to have some of the NDT presence, obviously, when you're looking at a case conference for a screening participant. But nevertheless, I think we're absolutely in that space, because I think we're in danger of trying to solve it within a model that is not tenable now. And I think that's the support that we need for screening, to think differently, whilst maintaining standards and safety.
I just say, just on that really, I think, and on Tamsin's point, I'm assuming that the deep dive into breast test will bring out some of this as well. Because for me, as well as the specialist roles, which I completely understand the ongoing recruitment issue, it's the we drop behind because because of sickness or leave, and then that raises questions about, are the people in the right place, cultures, floor teams, all of those sorts of things. So that would be really helpful if that comes out.
Yeah, just on the breast test Wales review, really looking forward to the findings. Tracy and I have met with the leads to discuss the initial findings in December. And I think there are some wider ramifications across the whole division that we will need to take a transformation approach to.
So the rest of this section includes updates on research, data, digital, policy, international health, and health and wellbeing in the pack as well. So I don't propose to go through anything, because I know we're short of time to get through the rest of it. So if there was any questions, then we can take them at time. So I move on to section 3, which is a strategy delivery. Start on page 43 for 61. Gives an overview of where we are with our delivery against our strategic plan. Really positive progress of the 244 milestones, 208 completed and green, so that's like 85% of our plan. We have got a number then which are amber, red, and we've also got a number that are paused or closed. And then we go into detail for each of our strategic priorities to give that overview against each of the priorities in terms of where we are in delivery against our plan. And then in this section as well, there's a overview of our strategic change programs, which is on page 51, which is quite self-explanatory. And there's also a couple of slides on the work that we've done around inequalities as well, and the update on the work programme there. So I'll pause at that point to see if anybody's got any questions on this section.
I welcome the work around inequalities. I had a quick look at the link. Yeah, it feels like it's a structured approach to work. So yeah, great, thank you. Thank you, comes in.
And then the last section of the IPR is section 4, which is the update on our outcome measurement. Sorry, struggling with my cold. So I'll pass to
Thanks. I mentioned it earlier, and I'm not going to go through it in detail, but I think rightly we've viewed the measurement system as a work in progress. And I'd welcome board feedback, because I think this is getting closer to where the intention was for it, which actually set out the latest indicators in this time from the School Health Research Network, both actually which had overall trend findings, but also had an inequalities lens on it. Then clearly sets out what we're doing about it as an organisation, largely in Jim's area. And then actually this one is probably in one of the better positions around evaluation compared to some of the other strategic priorities. It sets out clearly we're yet to get to the full outcome evaluations for many of them, but actually the outcomes are there. The outcomes are there for the deep dive on mental health, and the evaluations are underway. Now look forward. What we'll do is work with the team about when the evaluation is complete, so that we can then give that picture, so that we can know what impact we're having on it. In terms of the outcomes overall, I don't think it's not intended to go through them in much detail. It's a mixed picture. On healthy life expectancy, though, I will say that February, when asked for update with the latest data, so we can expect by the time of the next board to see more about where we're at on that.
Lovely. Tracy.
Yeah, we had as execs and some other colleagues talk about the draft IMTP yesterday, our strategic plan, people listening, which will obviously come through boards and should be shared hopefully in the next couple of weeks. And what isn't quite connecting yet is outcome measurement. We've got all the actions in a plan, but we're not bringing the outcomes to track those. So what I want on our route map is that we are tracking the outcomes that are relevant to the strategic priorities to know whether we're going to hit our strategic outcomes or not. So we did have a discussion about tracking those through, Ian, didn't we, into the strategic priorities, because otherwise this sits separate to the work of the organisation, and it's really good stuff, but it should inform action, focus, and if we're not looking at getting closer to 2035 and what's happening with these, what difference do we know we're making? I'm not saying we can control all of these, but we have to be pretty sure that we're contributing. So that's the thing as we go into the next year, is that repository grid that is really clear, so that we know which one is tracking which outcome through the strategic priority.
Nick, first, please.
I mean, totally welcome that. It's actually good. What the prompt for me when I look at the part of that question, and partly is, and this is probably showing my ignorance, is where do we sit in a more international sense? So we look at some of these markers, like a little bit of my picture is that's still slightly Wales in a disadvantaged position, and so it's trying to make sure. I'm sure certainly our experts, I'm sure, have that lens, and it's just understanding what your goal might be improved. The rest of the world might still be out improving us, and it's partly just about understanding where we sit and where we should be in that context. So that's which is the good thing about the report. I think the report is really useful in that sense. But what it does for me when I look at it is it points, okay, that but actually, does that goal actually put us somewhere where Wales deserves to be?
Did you want to cover?
Yeah, a few points around some of the more clinical measures. The UK, I would say, is low average across Europe on certainly the cancer, many of the cancer stats. But I wonder, Ian, maybe at future we can include, and Samina and Rebecca and the team can support picking out a number of these, because some of these don't always read across because they're meant into slightly different things, but to show a little bit of a clearer picture, certainly about how we compare with Europe, and maybe broader, if we're able to comparison. There'd have to be some caveats around it.
Oh, absolutely.
But it'd be interesting to
Welcome what you just said about the IMTP, because it kind of links back to Ian saying I didn't ask my usual question. but I think the outcomes is helping with some kind of tracking around that. So that's really welcome. But also, again, we go back to our strategic milestone delivery where we are, flying, we're smashing that. And so on when we look at what we set out to do, again and again, we're achieving that in a really significant way. But when we're looking back into the outcomes and the impact, is there a disconnect? Are we setting out to do the right thing?
absolutely.
Link into the outcomes? But yeah, I mean, we've been here before, but it feels like it's almost the crux of the matter.
If we're not making a difference, what are we doing?
Yeah.
Sometimes we need to be able to answer that question ourselves through evaluation, but making it really clear that everything we do is deliberately contributing to an outcome we're trying to achieve. And at the moment, we've got some of that, and we've got some that is who knows question. So, it's part of the kind of optimization of the organisation is aligning it deliberately to the so what question.
Sorry, can I just come back on that? Because the outcome measurement deep dive is also really useful. Giving us some kind of insights. But again, okay, so we can look at the situation, know that there's a difference between mental health, and we can look at disaggregate that and look at it more girls and it's lower income families. What are we doing with that? I mean, how long is the gap between knowing that this is the issue and us trying to implement something then to how do we effectively do something about this situation that we can see is happening on the ground. And, you know, is the lag so long that it becomes almost irrelevant that we're doing that work? So it's like we're at stage, I know I came in and I was like, kind of, where's the information? And now I can start seeing the information. And it's like, well, what are we going to do about that?
And we're doing a lot, this has all informed our strategic priorities, so I don't think people think that we're not doing, it's demonstrating impact, I think.
Yeah.
Ian, sorry, you desperately.
That's all right, you know. I didn't say it. No, it's, I think there's a couple of important points tied within this. The measurement system triangle had another arm to it, and that's the weak part of it. If you can have an arm to a triangle, that's but basically the other part of it was policy modelling. And the bit we're weak on as an organisation is taking the size and scale and that time horizon point, which you just made, Tamsin. So actually, none of us are going to deny that the smoking, the tobacco and vaping bill in the UK Parliament is anything but great news for public health. But actually, when you look at the impact on mortality, you're talking 10, 15, 20 years out. So that doesn't mean it's a bad thing to do. But what we maybe need to do as part of this, and it may not be perfect, is work out which are going to have, what is the size and scale of each of the commitments against the strategic objectives, and what is the time horizon for delivery of those and the impact of them, so that then it gives you as a board clearer sight that actually this is really important, really sets it out, but it will take decades in order to come through. Actually, there's some really important things we can do and do now, like having Claim can deliver much quicker, but not quite to the same scale. And how do we get that size and impact in there? So I'll accept the challenge on Louisa's behalf.
Jim?
Diolch Jim and Mel's Dewey, if I'm the kind of light bulb, the Hesiant. I think Ian's right. One of the things we need to get into, particularly if we're looking at blended strategies to improve life expectancy and reduce inequalities, is modelling what will give us the quickest or biggest bang and in the time scale. So if you look at, and I know that the chairs of Crick and USIC have been bored to death by me in the last few months, talking about our quality improvement work in health improvement, where we're kind of looking and we've evaluated a lot of our work on tobacco control to show that the more we change our campaigns, the more we drive up people into our smoking cessation services. That's great. But if you look at really modelling what the impact will be, there is no doubt that smoking cessation is only one thing alongside a smoking ban and alongside the legislation, which is why we put effort into that, which will deliver impact quicker. So, and if you're looking at the area under the curve in terms of how, deaths avoided and cardiovascular events avoided and cancer avoided, they all make a contribution, but some of them will make a contribution bigger and faster than others. So where do we put our money? So in diabetes, it's a bit of a no-brainer. The bundle of aid will give you more reduction in cardiovascular events quicker than primary prevention, but you still have to do primary prevention. And Ian's right, I think that's where that's the really exciting area. And I have to say, I don't think a number of the other bits of the UK are doing an awful lot better at it in some ways. I mean, some places are doing really well, but that's where we need to get into modelling what the impact will be in terms of 2035. What's going to get us to that healthy life expectancy? Now, I've got my teams trying to do that. I think one of the problems is that the methods you need for this are kind of split across data science, public health, epidemiology, and a whole lot of other places. And this could be our biggest opportunity if we get it right. Sorry, I'm quite enthusiastic about it.
Yes, I think that's the end of section 3. Thank you to my 3. Thank you, Claire.
Thank you. Thank you very much for running us through all of that. Very comprehensive. Oh, Maine, sorry.
Sorry report coming in late. I didn't know when to raise it, but it was in relation to a request for change, HPSS 039. I think there had been some email exchange, but culminated in probably the wrong conclusion in the board papers. It's not to suspend our liaison with the food, water and environment testing, but it's to delay it to December 27th, so it's the next INT. So we correct that.
Lovely, thank you for that correction. So let me just check then. I think we're all in a position to consider the IPR and the financial position of Public Health Wales as of 31st of December 25, and to take assurance from the discussions and actions. Everybody happy to do so? So moving on to the corporate risk register, and in Claire's absence, to you, Angela. Thank you very much. If you're okay taking us through.
Thank you. Just a quick overview. So as you know, the leadership team have responsibility for the corporate risk register, and recently undertook a deep dive into this, looking at how the actions were progressing and if there were any gaps in actions to negate the risk. We also consulted Bet on these after the deep dive, and so you have the latest version of the corporate risk register in the papers. Just to make you aware, there is one new corporate risk register added, which was relating to our failure to achieve net zero emissions. So that's a new introduction, and it's been accepted onto the risk register. We have had none that have been de-escalated, and we've had 2 risks that have been closed from the corporate risk register on its last review. So in total we have 10 risks listed, and they are included in the papers with the details against them. Happy to take some questions.
Thank you. Any questions, comments? Rebecca?
I'm doing the Rebecca Masters. I'm going to follow the ECHO providers. Rebecca Masters, the health consultant here for Sabina Rizam. I lead the climate change strategic priority area, and the decarb risk is one of the areas that sits within that programme of work. It was a point of clarity really around the risk scoring for the decarb risk, because it's currently at 820, but on review a climate change programme will put that down to a 12. So just to note that, please. We have enhanced new mitigations that we've put into place for that one, included dedicated resourcing, an update to our decarbonisation plan, which is now called our climate response plan. And we are preparing a set deep dive session for early February. We'll go into further detail on how it relates to some new IMTP commitments, which will be going in shortly.
Good news. Yeah, that's good news. Thank you for the update. That's really positive. Any other questions? Or are we all okay to take assurance that the corporate risks are being properly assessed and managed? I think we're all in that place. Lovely. Thank you very much, Rebecca. So committees of the board report. So the report sets out the work of the committee since the last board meeting, which was in November 25. I think all of the boards have met, so the written update is the final story. Has anybody got anything that they'd like to ask any of the chairs? Nope, lovely. In that case, can we take assurance for the work of the board committees as set out in the report? Brilliant, thank you very much. So if we can move on to 3.6, UK COVID-19 Module 2 report, and Paul to take us through this one.
Thank you, Chair. Hoping that Hugh Williams is going to join us as he walks in through the door.
Amazing.
Who's joining us?
No, it's not.
As Hugh said, preparing and settling in, the board will recall that in November last year, 20th of November last year, the Module 2 report was published by the Public Inquiry, looking into government decision making during the course of the pandemic. That report's now been digested into our executive team and then allocated over to Health Protection and Screening Services through May for the recommendations to be looked at through the lens of Public Health Wales, identifying and learning that we still need to take an action, but really to focus in on the recommendations, work out how applicable they are to us, and then to set in action a plan for us to assist in the compliance with those recommendations. So having set that scene, I'll hand over to Meg to take it.
Thank you so much. And the paper sets up the details of the report, its findings and the recommendations. So if there are any questions around those, then please do ask. Hugh Williams has been our head of EBRR, has been instrumental in leading this work, working with colleagues from across the organisation to understand what the recommendations actually implicate for us as an organisation, with our category 1 status as a major incident responder. We need to take this seriously in terms of what the inquiry has learned from all the witnesses and its review. So it's a comprehensive summary of our impact, and I'm just going to hand over to you to give us a summary of those findings and also the next steps in the governance around. Thank you.
No problem. Thanks, Meg. More than happy to give a bit of an update, and hopefully the paper really does provide some assurance to board that we've taken substantive action already as an organisation to improve our position. Some of those actions we've already taken include strengthening our emergency response plan, establishing a pandemic task and finish group that is actively working on updating plans, new plans for that capability to ensure that we're ready for the next time we have a pandemic, building on training across our emergency response capability. Well over 300 staff have been trained in the last couple of years in order to ensure that we're improving our position on a regular basis. We've improved communications and our situation reporting. We've had opportunity recently to test that through Exercise Pegasus, which was the national pandemic exercise that you'll be aware of from the end of last year. And we're looking as part of all of our plans well to embed those inequalities considerations really that have been highlighted through Module 1 and Module 2 reports that have come out from the inquiry so far. Looking ahead, what we're trying to put in place now is a clear and credible programme for that further improvement. So planning our next steps, developing expert skills registers as identified in the recommendations of this most recent report, enhancing our surveillance further and intelligence functions, improving accessible and inclusive crisis comms to make sure that is improved again, validating our arrangements through our exercises as well. We've got an ambitious programme of exercises that we're actively leading on and contributing to across Wales, and we're looking forward to contributing actively to the forthcoming review of the Civil Contingencies Act, which is one of those key recommendations in Module 2 as well. The actions really do align with our strategic priorities as an organisation, the Wellbeing of Future Generations Act as well, and our, as Meng has already said, the statutory duties for us under the Civil Contingencies Act itself. So I hope the paper itself is comprehensive enough to cover where we are at the moment as an organisation.
Yeah, and just to assure a board that there's a mechanism to take this forward, which is part of the governance for EBRR. So there's a subgroup looking at pan prep, which our father chairs, and that actually derived the draft pan response plan, pandemic response plan that we used in Exercise Pegasus to effect.
Thank you, Ward. It's a really comprehensive paper. Tracy first.
Yeah, it's just a big thanks to Hugh, our non-exec colleague, but no, Hugh, as well as we know him intimately as exec now, don't we?
Sorry.
But I mean, this is just one part of what the team are doing. The team have really transformed us as an organisation in our response to emergencies, and just thank you for your leadership, Hugh. I mean, it's just made such a difference there. So just a big thanks. I think it's really helpful. We've shared it with Welsh Government, who are also looking at putting their response together. I've said this before, Pegasus was really helpful in many respects. I'm more concerned about the chemical, radiological and nuclear threats. We lived through an infectious pandemic, we've tested subsequently, but we have not done anywhere near the testing, I don't think, across the UK around chemical, radiological and nuclear. So I know Hugh chairs the Four Nations Network, and we've been discussing, I've had various conversations with UKHSA and as chief execs of public health agencies, we say we need to exercise one or more of those this year, because given the global environment at the moment, we don't want to be in a position where we say we should be exercised it. So I think that's the thing for me. Whilst many of these in principle will support any threat, actually, they read across. And it's interesting to note that none of them are specific to us as an organisation, but actually more the content is relevant than the recommendations in many respects. So, but just to make those comments. Thank you. Paul?
Thank you, Chair. Yes, just to thank you for his input on this, for the work that he's done. And I think to give the board real assurance, you can see on page 13 of the report, the prioritisation for Welsh Government engagement and how we will work with our partners in the system, particularly Welsh Government, to take these recommendations forward in a way that's useful and tangible for Wales, bringing in the comments that Tracy just raised about all hazards approach. So there's a commitment there, and I think the requirement is that Welsh Government have to go back into the inquiry on their progress and recommendations. So we will hopefully have some input in that as well.
Lovely. And Meg?
One update from Hugh in relation to the CRN threats that you'll be pleased to hear. And the second is just to say that I think Welsh Government are minded to provide their response with, well within the 6 months. So I'm expecting it in the next few weeks. So we should take stock of them.
You? Oh, sorry. In relation to the CBRN Four Nations, yes. So we had our most recent Four Nations EPRR group meeting, and it's very firmly now on our work plan for delivery in the next 12 months. That exercise that you've been keen to see us progress with. And I think you were absolutely right. We could have done this as an individual nation, but I think there's so much greater value because of the interconnectedness between and interdependencies between our public health agencies in this space, of it being a UK event, if you like. And it was only talked about last week, and it's already generating an awful lot of interest. So.
I think it's a bit of me just to say, as a non-exec looking at this and remember reading the report, thinking, oh my God, that's huge. This is so helpful, this report, in helping navigate and understand it and see the kind of sequence of how it's broken down. Really, really helpful. And I'm amazed it's been done in this time period, actually. That's a lot to get, but really helpful. There's such a lot in here to get through it. So much easier than reading the report.
There were no pictures in the report. That is not good for me as my colleagues will tell you.
Lovely. Anything else? No, brilliant. In that case, I think we can very much take assurance that the organisation has considered the Module 2 report and is taking the appropriate steps in response to the recommendations. And just a thanks from all of us, I think, Hugh, for a lovely paper.
Thank you, Hugh.
So on that happy note, I think it's time to go to a break. We're a little bit late starting. So if we can come back here at 1:20, is that okay? Lovely, thank you. Good afternoon, everyone. And welcome back to the afternoon session of the Public Health Wales board meeting, and a particular welcome to David Rees and Rosie Dow and Emily van der Vita, who's also here to do the Arts Council session with us. So if I just pass over to Jim to introduce this section of the agenda, please, which is the strategic partnership with Arts Council for Wales.
Yeah, I will be very brief. And I'd just like to say a big welcome to our Arts Council colleagues internally. As you know, in health and wellbeing, we have multiple partnerships with lots and lots of people that have different impacts on health. We've had Sport Wales and I've got Arts Council for Wales. This is very different. But when you hear about some of the things that are happening, particularly with mental health, it's going to be really exciting. This, for me, is part of mobilising every organisation in Wales for better health for Wales. So I'd like to thank people for the leadership, and I'm just going to shut up on that and pass over to people who know what they're talking about.
Well, I go first. So I'll speak in Welsh as a quick introduction. Chance to speak earlier on. David wedi reid ar y treis, fi yw Prif Weithredwr, Cyngor y Celfyddydau. A diolch yn gyntaf, diolch am y cyfle i ddod yma ato chi heddi. Mae'r gwaith o ran y celfyddydau a iechyd wedi bod yn cael ei ddatblygu, sy'n ni'n dweud y ffwmpas rhyw 10 blynedd. Dwi'n gwybod bod e wedi tyfu ar ystro. Ac mae'n waith gath ei ddatblygu'n wreiddiol, dwi'n meddwl, fel rhyw fath o ymateb i'r deddf tresiant cydweithio'r dyfodol. Yn sicr oedd hwnna yn elfen ohono, ond oedd e hefyd yn elfen o fewn y cyngor celfyddydau, lle o'n ni yn gallu gweld bod ymwneud gyda iechyd, oedd pobl wrth gwrs yn gwybod bod y celfyddydau Cymreig gyda celfyddydau yn llesol i gymunedau ac i unigolion, ond benderfynon ni i geisio wneud yn fwy ffurfiol y ffordd, drwy greu partneriaethau, mae gennym ni partneriaethau gyda'r NHS Confederation, bron bob un ohonyn nhw erbyn hyn, lle bydden ni yn datblygu'r celfyddydau. Ac erbyn hyn, rhyw 10 blynedd yn ddiweddarach, mae rheini sydd yn ymwneud, mae corff yr enw WAHW'n sy'n cynrychioli ymarferwyr creadigol, wedi mynd o ryw llon llaw o bobl 10 blynedd yn ôl i tu ar y 100% o bobl erbyn heddi yn gweithio ledled Cymru. Fe fyddwn ni hefyd yn dweud, i ni'n ymwybodol wrth gwrs, pob un ohono ni am y caledi ariannol sy'n gwynebu cymdeithas ar hyn o bryd a chyrffen ni a chyrff eraill yn y sector. Ac felly mae'n bwysig i ni bod ni'n ystyried ein gwariant ni lle mae'r impact fwyaf i'w gael, ac yn sicr yn y maes yma i ni'n gwbl hyderus bod yr impact posib a'r impact ni'n cael ar hyn o bryd yn y maes iechyd yn rhywbeth ni'n falch iawn ohono fe. Mae'n waith sydd wedi cael ei gydnabod yn rhyngwladol. Mae'n un o clec prin, byddwn ni'n dadlau bod Cymru'n cael ei weld fel un o gwledydd fwyaf blaengar o ran y celfyddydau ar lefel rhyngwladol. Fe oedd yna erthygl yn y Lancet, dwi'n meddwl rhyw 2 blynedd yn ôl, oedd yn cymharu'r gwaith iechyd a celf oedd yn digwydd yng Nghymru gyda gwledydd eraill o gwmpas y byd. Dwi'n meddwl oedd 2 erthyglau o'r Sgandinafia i Australia a dyna oedd Cymru yn y canol yn dangos y ffordd ymlaen rhan yn gwaith ni. Felly ni'n falch iawn o hynny. A tua rhyw 6 mis yn ôl, bynnedd fyna ni bod yn bwysig i ni ddadlau ein hachos a eirioli dros y gwaith yma, ac fe gomisiynwyd darn o ymchwil arbennig, ac i ni gael cyfle pan awma, fi'n gwybod bod nifer ohonoch chi falle wedi cael golwg ar y ymchwil mwy o diweddar yna. Ond oedd e'n bwysig i ni bod ni yn ceisio yn academaidd mewn ffordd, yn trial rhoi gwerth i'r hyn roedden ni yn ei gyflawni. Ac felly dyna ni, that's it as a short introduction from me. Many thanks for the opportunity to be here today, and we look forward to discussions following on from this session. I think that partnership work is definitely moving forward, and we are very proud of the work we do in health. And I think there are benefits for not only yourselves and ourselves, but other elements in society as well. But I'll hand over now to Beverly and Rosie, who actually do know what we're talking about.
Yeah, Becky. So, as Alison said, there's a really strong foundation for arts and health in Wales. We, as Public Health Wales, signed an MOU with you last year. Yeah. So I wanted to come along and talk to you about the work that we've been doing as part of that. I suppose part of our reflection is, yes, there's great work happening. It's quite varied across Wales, and we've kind of almost hit a bit of a stalling point where we feel there's loads more potential that greater focus on arts and health activities could help to unlock, and we just need to kind of help work together to help push the system over that next step to really get maximum benefit from it. So you've had a paper circulated, which I'll take as read, that just outlines a few of the things that we've done together through the HAPAS partnership, including there's a focus there on the artist commissions. That was a particular aspect of the MOU that was specified as well. Touches on some of the evidence that Rosie will talk about in a moment as well, and then talks about how we as Public Health Wales are supporting the arts and health sector, so almost I would say independently of Arts Council Wales, so it's not quite right, you know, supported but informed by, but to really help realise some of those benefits, and then we'll touch on potential future opportunities to do a bit more as well. So I'll hand over to Rosie for the
thanks, Emily. Hi everyone. Yeah, Emily's given me the small task of summarising the evidence base for the relationship between arts and health. So I hope you've got several hours. Yeah, I mean, if I was actually to do that, we would be here a long time. This has been a growing area of evidence and research over the past 10, 15 years. Certainly since I started working in this area, research and evidence has grown massively, but there is still always a sense that we need more. And I think it's because at a sort of scientific level, we often don't understand the underlying kind of what actually is it, like what actually is going on when people engage in the arts. And also because, of course, when people do engage, it's not one thing that's going on, it's lots and lots of different components all coming together. So if you think about the range of health conditions we might be asking about when we're talking about arts projects, if you think about the range of art forms, and if you think about the range of ways that people might engage in creativity, you start to see the complexity that we're dealing with in this space. So trying to simplify it's quite difficult, but what I am going to do is focus on this kind of public health area. So what can arts contribute as a public health intervention? Is the arts a public health intervention? Should we be starting to see arts and culture as a health behaviour in the same way that we might see exercise, healthy eating, not smoking, not stressing, when I still probably need to work on. And that's really where the evidence is kind of taking us in these recent developments. So I'm going to talk specifically about two things that have been released. They've been released since the start of this year, so very hot off the press. And one of them, the first one is, that's just what we're going to cover today. The first thing I want to say is a quote from our Chief Medical Officer, who really is signalling this move in the NHS towards recognising the importance of prevention. That's not something I need to sell to you as an idea, but still in the NHS as a sort of service provider, it's a very challenging thing to tackle. But also it recognises that health as a concept can't just be dealt with by the NHS. It has to be dealt with in partnership with people outside and other systems and other offers. So we believe that the arts is one of those. And so, as David says, we commissioned Bangor University back in the autumn to see if they could use the existing evidence base, it's very, very strong and wide, as I've already referenced, to try to understand whether there was a financial figure that we could put on the health and well-being benefits of engaging in arts and culture in Wales. And we can understand health benefits in different ways. We can say, okay, are we reducing demand on the NHS, which is the primary area? Are we improving people's quality of life, their quality of life years? And are we improving their productivity, their connection to society, which also has kind of financial benefits as well? So we sort of just, the question we asked them was like, is this possible? Can we get to a figure? And the good news is, yes, it is possible. And they've got to kind of, they haven't got to kind of one figure, they've got to several. And so this is what they found. If we start on the left with the bag of money, what they found was that the estimated financial value of health and productivity benefits through all engagement in Wales is at least 588 million a year. They used a report that was commissioned by the DVMS in England back in December 2024 to do that. That did a really in-depth literature review and came up with these kind of models for per person financial benefits for health for engaging in the arts. And we've applied that, Bangor have applied that to population data from Wales to get to that figure. What they have said is that because the evidence in this area is still developing, this is likely to be a considerable underestimation. It's an incredibly conservative estimate. So then the second thing, if we go to the coins at the top, what we wanted to know is that obviously we invest public money, we invest 30 million a year in 81 arts and culture organisations across Wales. We were keen to see what that return on investment would be in terms of health and well-being. Obviously, that's not all the money that goes into those organisations, and that's why actually we've come up with quite a high figure. But it is it's often all of the public money that goes into them. So it's a really, really valuable and worthwhile figure. And also, that figure's so high, £11 for every £1 we invest in arts and culture through our multi-year funded organisations. And that's so high because attendance and participation in Wales at cultural activities is really significant. It's hundreds of thousands of people every year engaging in arts and culture in Wales. So if you think actually we've actually been through a really tough time with arts funding in Wales over the past 10 years, but we're still having this incredible benefit. You think, what more could we do if we had more investment? And this is the sort of place we come to this from. And then with the other 4 figures, this is where we asked Bangor to have a look at particular projects that had a potential to reduce demand on the NHS. The 4 that they highlighted were, one, Dance for Strength and Balance. That's specialised dance classes for people who are at risk of falls, and could they keep people out of hospital and out of ambulances, and how much could that save us? So if only 5% of the people that are at risk of falls did a dance class, then we'd save £5 million a year in healthcare costs. Similarly, for mental health, if 5% of adult mental health GP appointments were avoided because of arts engagement, and we know there's really good evidence that that can be achieved, that would save 17 million a year. For young people, a similar figure would save 9.5 million, and arts programmes that support NHS staff are also a really, really important part of this picture. Could save 3.5 million a year through reductions in sickness and attrition, which, as we know, are really challenging for our NHS colleagues. So the other piece of, the other publication that's happened is a book by Professor Daisy Fancourt at UCL called Art Cure, which is a deliberately provocative title. But in this book, she calls for arts to be now known as a health behaviour. And she spends kind of several hundred pages exploring all of the evidence for the arts in different areas, and comes to this conclusion that the arts needs what we call a seatbelt moment. So, you know, in the 90s, we all sort of recognised all of a sudden that actually we should all be wearing our seatbelts. She wants the arts to have a similar moment. And this is some of the data that's led her to believe that arts, she's used longitudinal cohort study data to get these results. We know that engaging in arts and culture across your lifetime will reduce your risk of chronic pain, frailty, dementia. It will also increase your lifespan. It will improve your likelihood of engaging in healthier behaviours in other senses. So we know that people who read for pleasure are less likely to smoke, use alcohol, and then more likely to eat their fruit and veg. And we know that for young people, they're at lower risk of developing behavioural problems and mental health problems if they're offered arts and creativity, particularly outside school. So in school is important, but outside schools have an even bigger impact. So Daisy goes through hundreds of pages of this, which I'm not going to go through now, but she concludes that if arts were a pill, it would do all these things. Increase happiness, and its associated neurotransmitters, give us moments of joy, regulate our emotions, but also improve our cognitive reserve, reduce pain, and reduce our engagement in other harmful behaviours. And all of this will contribute to an improved lifespan, which is something that everyone in this room is working towards every day. So it is hard to do a whistle stop of this stuff. It goes quite in depth, but if you are interested, I really do recommend that you have a look at that book. It's sort of, Daisy is offered to come to Wales and do a session for us. She'll be at the Hay Festival as well, so do look her up. I'm going to hand on to Emily now, who's going to talk about some of the work we've done with Public Health Wales and what we'd like to see more of.
Thank you. I've outlined this in the paper, so I wasn't going to dwell on it too much. We're really excited around the artist commissions, which I referenced. So we've got draft outputs, which are just being worked on now, to publish those new commissions next month. So those particularly focus on encouraging people to engage with creative activities, whereas previously we've done some commissions which encourage people to reflect on what matters for their mental health and well-being. We have supported conferences within the sector, so the Weave one last year, and we're supporting the Storytelling for Health conference for next year. Collectively through the Hackers Partnership, obviously promoting the national conversation, and really importantly, our Hacker supporters with that increasing knowledge, skills and confidence to support those that they're working with to improve mental wellbeing. And if any of you follow our Hacker social media channels, you may have noticed that this month has had a focus on creativity as a theme as well. So more in there that you can have a look at. I think one of our recent successes that we wanted to talk about was the Cynefin
projects that we've recently been funded to deliver through the next 12 months or so by Arts and Humanities Research Council. This will deliver a creative health review for Wales, so it will build on the creative health review that was undertaken in England. The recommendations coming from that were very English-centric, and cut across multiple government departments. We will focus very specifically on health and care, and recontextualise those recommendations for Wales and engage with stakeholders, people with lived experience, both of delivering arts and health initiatives and benefiting from them, to really identify what more needs to be done to unlock the potential and to really embed action within our health and care system. With our HAPAS partners, we're currently scoping out a model in terms of what would our offer be to develop a social prescribing offer for children and young people, particularly around mental health and wellbeing, following, come to previously, the recognition of the increased difficulties amongst young people, particularly emotional difficulties, which arts and health engagement can really help with. So lots of exciting things. One thing we would really like to ask of the board is we would be really keen to have a exec sponsor, a champion for arts and health. We could obviously talk about how that role could shape up, but one key ask would be to engage with the Cynefin process, and we'd have 4 network events through that, and part of the outcome of that activity is we create new relationships between sectors and create our new champions. I think those are the key bits, and then it's kind of what next. So we have some thoughts around maybe we can work with comms to kind of reposition engagement with arts and creativity as a health behaviour, given the powerful evidence coming out to support that. We are keen to explore, partly through the Cynefin process, whether an arts and referral scheme would be a benefit in Wales and what that might look like, kind of reflecting, building on the National Exercise and Referral Programme. We think there's perhaps opportunities to do more. We obviously had some arts input into the last Wales Public Health Conference, and we could build on that further. And then we've had an interesting recent offer from Arts Council around potentially looking at an arts coordinator post, which are embedded in 6, isn't it now? It was all of them, but that's 6 out of 7 of our health boards, and potentially we could look at that as something that we need to pick up on as well. Anything other to add?
Yeah, thank you. And I think the arts coordinator post is really about how we make the most of some of these opportunities and build this momentum without having to kind of drain the existing resource that you have as an organisation. But it also is because as an organisation, if we're thinking about things like a national arts referral scheme, what that might look like, one of the challenges we've long been aware of is that arts as a sector and as a policy area exists over here, and health exists over here. And linking the two in terms of language, in terms of resource, is really challenging at that infrastructure level, but it's also challenging on the ground. So if you're a person who is suffering from mental health problems, for example, we know from the data that you're less likely to engage in arts and culture, but you're more likely to benefit from it. And so we all have a responsibility to improve the links between where you might engage, which is with your GP, it might be with a mental health charity, with your family, and from those kind of spaces where it's becoming clear that you have an issue into the arts. You know, how do we improve those links? And so that's really where the capacity building programme that Emily's referred to, where we funded posts in each of the health boards, that's designed to do that and to start to build some of those links in a really intentional way. And it's had an absolutely huge impact. All of the health boards have now got embedded, most of them, but sorry, not all of them, but most of them now have embedded permanent roles focusing on the arts because it's been so beneficial to their health boards. And we focused at the beginning on health boards, but we've been very keen to widen out into the trusts and look at this more broadly. And so because of the partnership work we've been doing with Emily, this feels like the next logical step. Normally we would co-fund those with with whatever partner we're working on, so it would require investment from both sides. But we can see so many opportunities for how that post could be supporting these things to actually come to life and make an impact. That's my pitch to you. Consideration.
Oh, lovely. Thank you very much for that. And it's really good food for thought. I don't know if colleagues have got anything that they would like to add or ask. Oh, there's everybody. I was starting with Meg and I'm writing a list.
Yeah, I mean, accordingly, providing we go medical director of Public Health Wales. Really interesting work, and is I think other passion, and really struck by the rising number of people in the professional space who provide music therapy, art therapy, etc. Do you have some professional specialist groupings working alongside you? That actually provide services directly, whether on a private or a commission basis.
Well, I'm not sure I know exactly what you mean. Are you talking about arts therapists and
Yeah.
So I think I would normally understand arts and health as a space quite differently from arts therapy. They're definitely related, but arts therapists tend to work within a framework and a sort of medical setting and like I say, framework. Arts and health is mostly delivered through artists working as artists alongside a health professional. So an example might be an artist going into an inpatient mental health unit, and they wouldn't be offering therapy, they'd be offering art. They'd be offering an art session. There'd often be a therapist in the room because, in case anything comes up, also the space was safe. But most of the work we would fund through the Arts Council would be arts and health rather than arts therapy. I'm not sure if that answers your question.
There's what I expect is a spectrum, isn't it?
Yeah, it is.
Bridge the gap. I just wondered whether you had access to the whole spectrum of people involved.
Yeah.
We fund Wahoo that we on a year basis, and they represent 1,200 or 1,300 practitioners.
Yeah.
So we have that relationship.
Yeah, absolutely. And you're right. And there are examples of work and projects that have a therapeutic aim and benefit and are delivered by artists, but it normally is in partnership with a health professional. We would normally make that line quite clear.
Lovely. Right, I'm just going to run through this. I've got Jim and Neil and Angela and Tracy and Sian. Is there anybody else? No. Excellent. In that case, Jim, over to you.
I'll be brief. Just to give one example, when we brought together 60 people with diabetes, we had them talk about their experience with art facilitators to help them express it in prose and poetry, and in fact in song at the end of the day, which is weird talking about HbA1c singing about it, and it doesn't rhyme with anything either. But the thing that came out of that is that we're working on a point of diagnosis pack that will be shortly for people newly diagnosed with diabetes. The people with lived experience who worked on that pack said the fact that they spent that day writing about their experience that they found difficult to verbalise. They'd had some bad experiences. The art actually helped them identify what good was look like and will make tangible changes to people's health. So I've seen it firsthand. Having been a bit of a cynic in the past about some of this stuff, and I can really see the value.
Thank you. Yeah, and that reminds me of a project we're funding in the whole of our CAMS team with young people, where when a young person becomes known to CAMS, they're offered the chance to join arts workshops. What we're learning from that, not only does it give them more tools to support their mental health, and also what the staff are telling us is that it's particularly good for neurodivergent young people as well, to help them engage in their treatment better. But that the young people are reporting to them that they have a much better experience of CAMS as a result of also having the art workshops as part of that offer, to the point where I think their CAMS approval rating was operating at about 30%. And when people go through this project, it's 100%. So it's a really interesting question of value. What do we value in the health service? What offers value? What delivers value? Not just in terms of pounds, shillings and pence, which is really important, and that's why we've commissioned this work, but in terms of value to the people and to the services that we're working with.
Yep.
Thank you. Great pitch. I'm in. So I'm Neil Lewis, Director of People and OG. So just a couple of points for me. We're doing some work at the moment with HIW kind of across the system around kind of well-being. I can really see the workforce well-being piece, I can really see the links with this. So it'd be great to kind of explore that outside the meeting as well. We're also kind of the links for us within public health world. I can see some real opportunity here, and obviously I know you're doing lots across health boards and other spaces as well. So I suppose, yeah, which is from my perspective, would be great to kind of follow up after the meeting and see what opportunities we can kind of look at. So yeah, thank you.
Absolutely, thank you.
Lovely. Angela Cook.
Thank you, Angela Cook, Assistant Director of Nursing and Quality. Thank you very much for a great and enlightening presentation. The falls element really resonated with me, both on a personal level, but also as a system level. What a difference that would make to the system if we could enable that. The other bit for me was really around that self-referral scheme. We get a lot of phone calls every week, particularly around mental health, coming into our complaints line because people see us as a conduit, if you like, and where they've got nowhere else to turn. And so we often signpost out to Samaritans or NHS 111 services. But wouldn't it be great if we could sort of refer to a self-referral scheme as well, or signpost? So I'd be really up for that. So thank you.
Yeah, not everything has to happen through a medical professional. That self-referral is really important, especially when it comes to the arts. It's all about offering choice. Not everything's going to be for everyone. So yeah, you do need to have that route always open. Thanks.
Thanks so much, both of you, and obviously Emily and Jim. It's we were talking earlier, saying that we've had a long relationship with Arts Council over the years, but it's only been with yourselves that we've been actually managed to get a bit of traction in it. It's just the timing hasn't quite worked. So I think it's so powerful, and of course, Wales is our heritage is arts and culture, isn't it? Just a couple of points for me. It would be great to have the link to that. I think the link's come out actually for your report, isn't it? If I can share that through NHS colleagues, just to raise awareness of that. And as NHS chief executives and the exec team in the health group in Welsh Government, we meet monthly. Then if it's helpful, I can pick it up with the Director General for Health to see if, because we've done on and off over the years, invite you along, because I think it's really quite powerful and it would be a refreshing conversation to the normal discussions that we have. So if you're interested in that, that may be worth doing. And so a couple of specifics, social prescribing, and I guess how we can help mainstream into social prescribing, because it's just so key, and social prescribing just has not stuck yet, as far as I'm concerned, enough across Wales. So how do we work together with you on that? We talked about maybe a joint summit. I know you were looking at doing one this year, and if we can help maybe do a kind of joint one around arts and health, and that would be fantastic. I was going to make the point about HEIW, Neil. I think that's a really good one. And I'm also conscious that the opening of our health conference last year, we had Duke Al and Dom Soy as opening, and Duke Al is a recognised poet stroke rapper, and Dom is an artist. So we have a combination of poetry in prose, in song, in rap, and painting going on at the same time. And I met Duke Al yesterday. So I know we put a joint application in for NHS Poet Laureates, which is kind of cool. And we were talking about using Duke Al to do some engagement around community by design, using poetry and art and drawing to get views of different communities about how they would want to experience health in the community. So I think it's so powerful. Yeah. And then the final thing about the ASEC sponsor, we'll take that away because we haven't had the conversation on it. But I think the thing for me is, as an organisation, we need to think about, are we doing enough for our own staff in enabling support for arts, in relation to arts and health. And I think if we have that exec role, then that would be key to do that. So yeah, count me into, I'm in Neil's club. Yeah. Sian, over to you.
Well, Tracy, you've just spelled out many things that we can obviously do as an organisation to support taking this forward. And I was just going to say, I'm really impressed by what's going on, really support taking it further forward. And I just wondered how far you were off from the seatbelt moment, whether the reception is always positive and whether we can actually help to engender positive reception to the ideas of arts and health in any further way, because seatbelt moment was so as a sort of fundamental concept in public health, and it would be great to know how far off you think we are.
Yeah, I think that's a really good question. And what I've been doing this quite a long time, going into health spaces and advocating for the arts, and I feel that everyone in these sorts of meetings really does get it and is incredibly connected and understanding and listens to the evidence and wants to do what they can to help. And that's not always been the case. And so it's really positive to see that development. Unfortunately, at a population level, what the data show is that people are engaging less with the arts over time. And there might be many reasons for that. Some of it might be to do with some of the dismantling of our public infrastructure around the arts. In this country, local authority funding has gone down and down and down for the arts. And that's they've been a huge and sort of quiet investor in this space, particularly when it comes to community health and wellbeing through the arts. So that's a real challenge. If there aren't things there that people can engage in, then that engagement is going to go down. But I think there's also lots of kind of competing for people's attention as well. So that's why I think things like the campaign around arts as a health behaviour, could really help bring it to life in a public sense. Because I think from the health profession sense, people are getting it, but the public aren't quite there yet.
Thanks. Just a thought that Michael Sheen has just managed to grab the headlines, across UK with his initiative for the National Theatre of Wales, and I'm sure the Arts Council have been part of that whole drive, and I was really impressed by that because he's really sort of counterculture in engendering enthusiasm in theatre. So just a thought of whether he might help at all.
Pass that to you, Darren.
Well, he did help. He did help with the Royal Society of Public Health once. That's why I said on a campaign, along with Caroline Harris. So it's just just a thought.
Maybe he could be someone we could approach, or because anyone high profile like that in our Cynefin review would be a fantastic asset.
There might be people, this was
Great. Thank you, Sean.
Thank you, Sean. Brilliant. Well, thank you so much to all three of you and to you, Jim, for the work, but also for today's presentation. You've got lots of thumbs up, so that's a bonus. You're, of course, very welcome to stay with us for our deep dive into strategic risk 3.
We were just talking earlier about Jim, Emily and I've been over maybe doing a follow-up with David and Rosie at some point just to regroup around the conference.
Yeah, around something.
That would be great. I was just going to say, dear Kamari, thank you very much for your time this afternoon. And certainly the door from our point of view is totally open to speak some more and see where we can take this. And I love the positivity of the room. So, dear Kamari.
Thank you. Thank you.
Thank you.
I was just saying my sister's had cards, and I said I phoned her last night. She's not coming to this meeting, are you?
The arts factor.
Yeah, she's Dab is number 2. So
I saw the name. I was like,
yeah.
Right, for the rest of us, I'm afraid we are on to deep dive and approval of strategic risk 3.
Don't sound afraid.
No. but Nick was trying to leave, so I just took that. No, sorry. So it's very important actually. This. So I'm really grateful to all the work that's been done on it. So if I go first of all to you, Angela, in Claire's absence. Lovely.
Yes, thank you. So just a quick summary. This paper it sort of reflects our overall dynamics to triage risk environments. As board requested a rolling programme of deep dives. This is one such deep dive. To draw your attention to the residual risk score against targets, the risk assessment that's been reassessed, the revised assessment of controls and gaps in controls have been reviewed. And so you've got a summary of the updated mitigating actions and with accountabilities added in. The links to the corporate risk register are included in the paper. And to note that there is a revised risk score of an increase from 12 to 16. And I shall hand over to Meng to take us through the actual strategic risk 3 with Tom. Thank you.
Well, thank you so much, Angela. And, board will know that strategic risk 3 is relating to the delivery of excellent public health services, which is our strategic priority. But this risk focuses on those services delivered by health protection and screening services. You will also know from the earlier discussion that there are some performance issues and concerns around the delivery of screening programs that have continued, and the actions to improve will take time to embed. And whilst we're doing that, there's also a notion of significant transformational change within the screening services that will improve services, but will also, in the interim, apply pressure to the teams to actually continue delivering excellent public health services. There's also an ongoing investigation of our sexual health services, which we are working through to be able to articulate the full issues with a bit more detail, to understand the impact on the ability to deliver excellent services, which is an ongoing issue. And when that reaches culmination, we'll be able to provide more detail on that. So in summary, the reason for increasing the risk is to understand that the impact has changed. So we've increased it from 12 to 16. So that we reflect the dynamic nature of the risk assessment. And we know that this was raised from 9 to 12 in August last year. So it's in keeping with our ongoing review of this risk. In addition to that, we took the opportunity to include more detail and actions to mitigate against this risk, and also update on some of the controls to further mitigate the risk. I'm going to hand over to Tom, who's been leading a lot of work with Martin and the Director of Operations team to seek further information and also put in place further actions to mitigate this risk. So if I might come to you, Tom, to talk us through some of that detail, would be most welcome.
Yes, of course, Meng. And if I could possibly ask Liz if she could invite Martin to join us, if at all possible, in case there's any detail about the process. Thank you so much, Liz. Really appreciate that. So I think it's worth noting that part of the rationale for increasing the risk is that we certainly have a feel, I certainly have an approach that you are better to go and recognise risk and then row back from that than the other way around. And there have been a number of sort of issues that have occurred recently that, as Meng has said, suggests that there is a need for us to increase the risk score, and therefore outline in more detail to give assurance that the actions that we are taking to address that particular set of risks. So we took the opportunity to revamp and include a lot more detail. I think that there are some things that we're doing that you should take assurance of. There are also a number of things that were historically not included in the risk, but part of our lines of defence model that I think, because the risk focused on slightly different areas, we didn't necessarily include. So, for example, it's been noted as a sort of a success, the ISO accreditation of all of our infection microbiology laboratories, but that wasn't stated as a specific line of defence and recognised. So we've updated to include not only the things that we're doing, but the things that are new, but also the things that we're doing around that traditional model. In terms of the specifics, I'd just like to sort of refresh people's memories quickly on the sort of 3 lines model of defence that we take to address the risk. So the first line is operational management, which sort of looks at operational controls and reporting. There is always a risk with regards to that, in that, sorry, not a risk, but a potential weakness, that things are not escalated early enough or clear enough, and you need to have checks for that in place. And controls that we have around that are emergency response and business continuity plans, SOPs for clinical and non-clinical protocols, divisional delivery assurance, quality audits, peer reviews, and operational improvements frameworks such as the excellent operations, and then divisional clinical governance and systems plans. Second line of defence is risk and compliance, and that's a structured governance with clear committees. The potential risk there is around early warnings lacking enough sufficient visibility at the board level, and we're now addressing that via revised assurance reporting. I should say these weaknesses aren't necessarily actual weaknesses, but potential weaknesses in our line of defence that we need to guard against. And we're, in light of the sort of new issues, looking at screening dashboards and strategic performance reporting, developing our risk registers, and we are moving certain risks up to the corporate risk so that there is greater sight of that. QSIC oversight, and we have, you'll be aware of this, for screening reports due with specific focus in screening on bowel, diabetic eye screening, and breast cancer screening, as well as the, not for the next QSIC, but in train at the moment, the breast cancer screening review that has been commissioned by Meng and the organisation to look at how we can define and improve performance in that particular area. And then there are our corporate processes around quality of duty of quality, clinical audit, etc., and divisional quality leads and reporting, and programme oversight via IMTP alignment. And then the third line of defence is the internal audit, which gives us an independent review of governance and performance systems, and internal audits provide us assurance on clinical governance, on screening services, on transformation programme oversight, and leadership and maturity. So we have those structures in place, but we have needed to strengthen those, and for that, in terms of actions taken, we're in the developing strategic recovery trajectories for each of the national screening programs that are not meeting the performance levels or metrics that we would want to achieve the standards. There's been executive to executive engagement with the health boards around certain issues within that, in terms of addressing diagnostic pathways and bottlenecks. There has been I've already mentioned it, but the Breast Test Wales review, and that will lead to a series of recommendations, and we're assuming that will have an oversight, bringing reporting into that. And then we're strengthening our assurance reporting into both our directorate management team and our QSIC to improve the visibility of early warning signs. We're strengthening the digital governance and portfolio management, so a key issue for us, and I think that this is a universal a challenge across the NHS, but is the digital structures that we have and how we change and adopt that is a difficult and challenging area. One that I'm very grateful for the support that Ian brings, and we have re-established bi-monthly strategic digital meetings between HPSS and the research data and digital execs to work on focus and gain alignment around areas of work, mapping coordination between different projects and integrating the sort of clinical safety work, digital clinical safety work that's happening in that space. What I'd reflect is that there's a lot of need for change, and there's both a capacity challenge and also a readiness challenge. I hope that Ian will forgive me for quoting him, but he made the point that we've seen digital advances now so that we can almost digitize any process. The question is, how do we get to make sure that we digitize the right processes and have the transformation? And that's a set of business skills as well. We can't just digitize what needs to what is existing and what is there because that's what's been forced to be there historically. We have to actually develop for the future to make it fit for purpose for the future. And that has its own set of workforce challenges, both on the digital but on the business side as well. And then we are looking at our incident management and governance and assurance, and so there are a series of actions in that space. You will see a number of reports in the risk on emergency preparedness and resilience, and I'm aware that you already had an update by Hugh on this. I've got to say, I understand that the ask for this deep dive is to focus on more current issues, and I wouldn't like to suggest that we're not that doing great work in the emergency preparedness and resilience space, and hopefully you got that assurance earlier today. But I would just like to reflect that, you know, the potential for a new pandemic or a large health protection emergency incident remains a really key strategic risk for us, and therefore an area of focus that we continue to work on. And you'll have heard updates around Pegasus and Module 2. And actually, I think it is important we recognise the need to continue to work to build in the lessons from that, assessing whether or not we have to change and how we have to support the system in that space. But that's sort of what I would class as ongoing work that you need to be aware of to be assured, because you'd be expecting us to do that. Finally, I'd just like to quickly touch on support around workforce sustainability, and we're undertaking strategic reviews of regulated professions, looking at retention and training that's needed in that particular space. We're working with HEIW in this area to think about future pipelines for skill sets, and looking at how we can strengthen our commissioning and oversight for education and training. And then finally, there is innovation and quality improvement, and of course key to that is the route maps that have been developed, which we're now starting to implement within our 3-year sets of planning. So I am aware that there may well be more detail, particularly around screening and the screening plans that are being developed at the moment. And I know that there is an intention, once those have been completed in development in their current format, so they're outlined and they're being actioned, but we're looking at the best format them in. And I believe, Tracy, you've indicated previously that we want to make that available to board members as well, so that they can monitor the progress in that particular space. So that remains a very advanced work in progress, and we're actually acting on it, but we're getting the things into the right place so that they can be fit for purpose tools used to drive recovery plans, as well as just being reporting in here, where I think we felt you wanted to see the detail. So that's my sort of canter through of where we are and the changes. Meng, I don't know if you wanted to add anything, or if you wanted me to ask Martin to just cover any of the sort of specific processes that we did to update the risk.
Can I just say, I think Nez will need time to ask questions, so just...
Oh, sorry. Yes, of course. I will stop there.
You covered a lot of the detail, so let's leave it there. Thank you, Tom, for that very comprehensive update.
Yeah, thanks, Tom. Thanks, everyone. And Nick is first in.
Was I? Yeah. Really good. Thank you, Tom, as ever. Very good, very clear. On that, it strikes me partly from your opener, Meng, where you talk about the transformation change in there, and actually bit that you said earlier on today, Tracy, around we talk about the eye care and looking at things through a different lens. And transformation is a key part in here. What I'm trying to look at from a board point of view and an assurance point of view, sitting here as a non-exec, and I take this from my other life that I do, is I assure big programs. I look at big programs which are meant to be transformational. And the most frequent thing we come across is we talk about the word transformation, and either we're doing incremental change, which is not transformation, or we're doing transformational change, and you hinted at it, Tom, and what you were saying there. But what we get is a drive from the people in the workforce to try and, frequently it's in a digital context, digitize what they do today and resist proper transformation. And so, and it's not just in the digital space, it happens whenever we use that word. And so there's a bit for me in the board about where do we get the assurance that we're genuinely doing transformation and that we're making sure we achieve the objective that we wanted to. And when we do it with a digital hat, to get the investment, these are big investments. And to make sure that what we don't do is just bring a bit of expensive digital to keep doing what we've always done and frankly not add a lot of value to the people of Wales. So there's a bit for me where some of it, I know from the digital, we look at it through a lens and it creates. There's a bit for me about, should we separate and have somewhere where we're very clear about we have an observation of the transformation? So when we want to label something transformation, we're really clear it's transformational, and we're really clear that we're helping basically on achieving that objective. And that's not about steamrolling over people, that's exactly what you said, and that's about how we support our people to help them make the transition to something which it certainly should be better for the people of Wales, and 9 times out of 10 it will be better for the people in our services. So there's just a bit for me about how we make sure we get that lens and we don't lose some of this. The bit she sent me, by the way, I really welcome the deep dives. I like actually how it's structured and come out. I think this is helpful, and it's helpful for the kind of debate that I think we can have. But the lens in my head today, which started with when you mentioned the word quite strongly in your bits, how do we make sure, or how do we get assurance forward that we're genuinely going to achieve transformation and not just incremental? Because as you said, some of these things, we're not going to achieve it by just doing the same as we've always done. So we've got to do something different. So it's a bit about how you're going to do it, but the real bit for me is how do we get governance at the board level to make sure that we're able to get assurance on that as we go forward, if that makes sense.
Shall I come back?
Do you want to come back on that?
Yeah. I'm absolutely committed to full-scale transformation. So the BTW review will be the starting point to identify those areas that we need to focus on. But my kind of medium-term view is that I recognise the need for transformation, and it's not just about projects here, projects there. We need to bring it together to include very fundamental things around the structure. So taking the structure, process, outcome framework, I think we can then put together a plan for transformation that really talks to that ambition about making really significant, impactful changes that actually deliver against our promise to people in Wales. So how we do that, I mean, clearly it needs careful planning. So the discussion around the Best Test Wales review will give us a starting point. I don't know at this stage what that will look like, but I think these things have to be planned very, very carefully. It will need to be resourced and supported, not from existing resource. We need additional resource to bring in to actually have that expert view. So there will be some degree of external review and independence to this. Now, I know the division has previously had such a review. We probably need to revisit the findings of that and not forget what we discovered at that time. But I do think it needs a fresh pair of eyes, and it needs a very high-level strategic view of what are we aiming for here.
I'm going to just come back briefly, I suppose. I think that's great. I think the bit of lesson that we take from other places would be that the trap that we could fall into, hopefully won't, is I go to many organisations where the exec are absolutely committed to their transformation and set off a programme to do transformation, but that resistance we talk about means you don't get it, but you don't know you haven't got it until it's too late. So there's a bit about how you do that. And I would also say it's a bit of mirroring of what I know Ian, this director, trying to do right now. the agile approach sometimes gets you there to kind of do a full review and a full setup. Rarely gives you transformation effect because you spend so much time trying to do the planning and the bit for transformation that actually the service isn't going to change by the time you get to the end point. So it's a bit about how we enable it with proper expertise. But the ambition sounds absolutely right. It's just how then we at board make sure whatever that ambition is, that we make sure that we're assured that we're definitely getting towards it in whatever mechanism that is. So I'm not questioning the ambition. I'm just making sure that we can make sure that it doesn't slip and that we do achieve it, because it will take investment and we want to know we get the outcome from the investment.
Yeah, I mean, I could talk about this all day. I mean, just firstly, thanks Tom and Martin, Meg and Sharon is not in the room. There is a huge amount of work going on at the moment. And, you know, it's we've got screening programs that are doing really well. You know, let's not forget the ones that are doing really well. But we also, but we have to focus on the ones that we are not. We're falling significantly short, some of which I think are very much about our own devices, and some are obviously the relationship that we have with other partners. So just to really recognise that and thank everybody. I mean, I use a word about our frame of reference. We see the future through the frame of reference of where we've come from, and I don't think we've got skills to really transform. And when I don't like the word transformation because I think people think it's kind of fiddling around the edges. To me, we have to jump over managing forward to accelerate into a future state, because it's not worthwhile doing little bits and bobs. You know, technology is such where as long as we can define through the lens of the people who use our services how they want to interact with us, because that's the important thing in the future. And then we bring technology in alongside that. We look at service models, we look at workforce, etc., rather than managing forwards, which is what can we do to the current model. So I want us to be absolutely park where we are and step into that world. And I totally agree with Meg. I think we need external support, and I'll come back to that, and fresh eyes through probably a couple of different industries. Sort of like a hack. We could almost do a screening hackathon, couldn't we? Yeah. Because I think that would energise the team as well, who are kind of on the grudge of trying to do the day job, and it's just not working because we haven't created the environment and the system for it to work, because it's tough stuff. And if we can't imagine that future, we're going to be a lag. We'll be constantly on the lag. So I think there's a bit of work to do to think about that. But we need a fresh pairs of eyes. And Nick, I think it would be great to get you involved in some of that as well, to bring it a bit of a challenge. And I think for me, and I know Meg is spending a lot of time working this through, it means we've got to have the enabling system of management within our screening services, where we support people to be more agile, not to fear the future. And that's a huge people and OD element, Neil. So because it is where it is what it is, and we've got quite traditional approaches in some programs and really quite innovative in others. So I think we've really got, and we need to focus on that. And so I guess in the here and now is sharing the implementation plans, the recovery plans, when we're happy putting them through the rigor. And I just wonder at some point, not the next one, but we have a board development session on this, because I think that would be helpful. But I think we do need to inject some really different stimulation of that innovation, because actually it's about innovation more than transformations.
So I know Tamsin wants to come in, but Ian, did you want to come in on that point?
I'll come in on these points because I think it's all related. I think we've got a position here where we do have to think very differently, because there are risks by doing it service by service. Because actually England did the work, and 95% of the functionality of a screening programme from a digital perspective is common across the English programme. And so we've got to make sure we use that. But equally, when I look at some of what Jim delivers and how we could, actually a lot of that is the same functionality. And then we actually know you've got it from vaccinations as well. So actually some of the bits we might need may already exist elsewhere in the system. So how do we do it and knit it together? And I just wanted to slightly amend what Tom said about the governance, because the discussion with HPSS is really important to get this joint working, as Nick said, to make sure we get the digital and business transformation going. But the reason we have the Digital and Data Design Authority is to make sure we take that cross-organisational view, and that is the official governance for making sure we get that aligned with our strategy along it. So I just wanted to bring that in. I think there's a real opportunity to do something really good and transform it. But I really want to emphasise what Tom and Tracy and Nick have said is actually digital can do whatever we want it to do now. Just be careful with what we want it to do.
Tim, sorry.
I mean, a lot of the points that have been raised, but for me, I was going to ask when Nick initially posed the question about transformation is what is an example of something that is transformative vis-a-vis making smart, significant changes in the service that we already have, which was struggling. What was an example of how transformative can you be transformative? So, I mean,
I'll actually go with Tracy's definition, and in fact, I've been using this in another job nearby recently, which is it's about innovation that leapfrogs where you are. Some of our services have grown incrementally over the years to be where they are, and actually because we didn't have the benefits we have now. And so it's looking at it's reminding yourself, what are you actually trying to deliver? Yeah. And we're being constrained in the old days by paper. Then we went to email, and then we went to that. And actually, you don't need to be constrained by anything anymore like that. So the example I've used in the past, and I'm not deliberately trying to bring up today, but when you look at other countries that don't have our infrastructure, so fundamentally South America is one of the main places. You'll do things like buy photographs and retinal. They will do that by sending a device. They can ask them to do it with a mobile phone, and the technology is in such a place now you can do that. They send digital stethoscopes out to people remotely, plug it in on a conference call, and you do the same diagnostic you would do by visiting your GP, because they don't have the infrastructure and distance. So people around the world are innovating because of their circumstance.
Yeah.
We in Wales could look back to leapfrog into a place where we're not constrained because of where we started from. To me, that's proper transformation.
So,
but
so it's not for probably something to do with the board.
So it does feel like there's two separate pieces of work. Is that we need to keep trying to improve.
There's a now, and then there's the future.
Yeah.
And they meet.
It's the fix.
The transformation part that Nick's then describing does need to be taken out separately, really, because you're talking about there's invested interest within that a current service, aren't there? So there's agendas, there's vested interest, there's like protectionism almost around it. You start talking about crazy transformation where you're cutting people out, they're not going to be committed in the same way to something that almost like we just mentioned, like someone's separate to say, okay, take all of this away and what could we do? Because you're never going to get radical crazy change. People's
just like application, it doesn't necessarily mean cut people out of jobs.
But it can be so perceived in that way.
Just in the interest of time, and I know I've got other people waiting and an opinion that I obviously want to share. I will just go to Tracy quickly and then to Rebecca.
What I was going to say is what he said, but also, I think a great innovation that we're doing is self-smear for communities that we know have found it hard to engage with the system. I mean, it's a minor bit of innovation, but it's also a major bit of innovation for someone's life. So I think that's a great, and the team have lent into that. I think for me that we'd have to be clear on what good looks like. We've got to engage with our team to do that. But I don't want to be in 3 years' time or 2 years' time. I could be a 65-year-old male awaiting a diabetic eye screening and an abdominal aortic aneurysm. I get a text message because I've already said engage with me by text that says press this link. You're due your scan for both scans in the next 2 months, and it takes you to a link. And actually, if I go to Mould, I can get both done on the same day, or maybe I want to go to Cardiff. So the choose and booking a choice element should be there. There's not, and the booking system should ripple. We can easily do that. So even from making it easy for people, rather than a letter that's quite technical through the post, and I think, oh, I'm not going to open that because it's got NHS and Navscape. So there's a number of processes that we need to feed through to understand what good should look like, can look like, and we're not always the best people to articulate that because we don't know what's about.
about the transformational change element, what could that look like? I think the joy of the positionality of the public health system in Wales is that we actually hold a huge amount of these levers within our own gift, as opposed to the rest of the wider public health system where it might be fragmented. And so looking at the cancer screening programs which are more challenged, they tend to be in those areas where the disease is more amenable to prevention. So actually, how do we utilise our resources across the directorates to answer the challenge of who are the population most at risk and how do we support them to have a better health outcome? And I was minded to thinking through, well, which bits do we all own within our directorates to be able to pivot to answering those questions. And we have behavioural science. How do we enable better behavioural science communications to get people through? How are we having behavioural insights informed conversations between clinicians and patients, then really through that patient pathway? But then how do we utilise our economics and modelling skills to better be able to understand, well, how do we have those conversations with partners to say, yes, there's a need for you to invest in this space, but it's because of this. And actually, you might not see that return in the next 5 years. But if we don't do that, the cost of that to you as a service provider will be so much bigger than it is currently. And we don't hold modelling capacity generally within the organisation. That tends to be something we have to buy in because we don't want to hold that resourcing, and it comes back to that earlier around agency spent admin and clerical. Sometimes there are areas where you actually need to buy that in to answer the tricky question that I think we've got. So it was just a point to that transformation. I think each directorate has a part to play in that cross-organisation transformation.
Okay.
Yeah, really welcome that, Rebecca, because this has to be a cross-directorate endeavour. This has to be us all working together to deliver our aims, and really welcome any additional input to that. I mean, there's really a lot going on working across directorates. So behavioural science unit that they're looking at our letters and our techniques. They're on Untitled Chapter, which is our research group with our university to look at innovation. I think some of the ambitions around transformation, I wouldn't say it's held back, but it's constrained by the UK National Screening Committee recommendations about what good looks like. So even the model of camera that we use is defined to that UK recommendation, and to go outside it would require us to have a really robust rationale. So I think for those that are not connecting with us, absolutely, let's try everything we can to get those images. So one of the things that we discussed recently is those that are amenable to domiciliary care, who have domiciliary care workers going in, who aren't able to come out for screening. Well, can we use those handheld cameras to actually take the pictures through that service? Because otherwise, there's no other alternative. So we're thinking about those things, but some of the constraints are about what's already defined for us, and it would need policy decisions for us to deviate from it where there is no evidence base. So, we do it with some caution that the leapfrogging is careful, it's risk assessed, so that patient safety is absolutely at the heart of what.
And we can pilot it as well.
And we can pilot it. And then I think, going back to, I think Sian's point about, well, how do we build our narrative so that we can influence the system? What is the impact of delays to the whole system? And the modelling capacity is one that we probably do need to consider across the organisation.
So, yeah, again, for me, thank you for the bit of work. It's so useful, and every time we talk about this, we get into an elongated conversation, which I think shows that everybody cares very passionately about the particular issue. I think I've just got a couple of things to add myself. One is which I think in that transformational space, in that innovation space, we've got to take everybody with us. I don't think we can do the work and then present innovation. So I think that's where you do get anxiety. So it's great to have Claire. I know Claire's always with us from a union perspective, but to have that engagement. But for me, and I would say, I know I always say this, but it's about public engagement as well, because I think we'll find the public are ahead of us in some of this stuff. So, it's just really important that we do all of that in the transformation space. But then just to pick back up on what Tamsin said, in the short term, looking at our risks and looking at our risk tolerance, you know, we will have some actions that bring that down in the really short term. And some of that is going to be much more mundane, I would imagine, but just it's so useful to have it, and just and for the agreement to bring it back to QSIC in a different form. I think that kind of higher level of visibility for me in that role is really important. So thank you for all the work that's been done. Thank you for joining us, Martin and Tom, to listen to all our views, and we look forward to seeing the next iteration. Right, hang on, we've got to do something. So as a board, we need to take assurance from the updated board discussion. So I think we can safely do that. I'm looking around. Yes, lovely.
May I just say thank you very much for the discussion as well. I think the conversation about transformation and innovation is incredibly helpful, and actually there's some thinking for me, at least personally, on how we demonstrate and distinguish between that. So I found it really useful, and that will probably lead to further iterations. We'll continue with what we're doing at the moment, but we'll plan that in so that we can bring it forwards. And I'd just like to say I really agree with Nick's comments about how we demonstrate it, and also it's not easy, but actually it is so exciting when you can achieve it. So thank you for those comments, incredibly helpful. And I'll leave you now. Goodbye.
Thanks, Tom and Martin.
Okay, so we're moving on to item 6, which is items for approval. And the first one is the minutes and action log from the November board meeting. So any comments on state minutes? No? Excellent.
Yes, one. Sorry. Yeah, sorry. I know you're trying to get on.
No, no.
On page 13 of the minutes. There's a bit where I apparently it's the second NE from the top of the page, query the current innovations and improvement projects were sufficient. Actually, the question was whether we had the resources were sufficient, which I see is why the second paragraph, the next paragraph says what it says.
Agreed with that. So subject to that little amendment and correction, are we all ready to approve those minutes? Yes. Lovely. Action log. Paul, are you okay taking us through that?
Yes, thank you. Just there's 4 actions proposed for closure today. I won't go through them if everyone's content.
Absolutely. Lovely. Yes, great, thank you. And then we're moving on to ratification of chair's action. So we're asked to ratify the chair's actions and note the application of the common seal. Happy to do so. Yes. And then we're on to items to note. So again, I don't tend to give any time to these because these to note, but has anybody got any points they want to make just generally? Candy.
Just a quick flag. 8 February's is in the call with us as the board today, and we put forward the annual audit summary from Audit Wales. So just thank you to Claire for professional support of us from an Audit Wales perspective over the last 12 months.
Yeah, thank you, Claire. So on that basis, as long as we're just happy to note that, just do closing administration, which is any other business. No, lovely. So the date of the next meeting is the 26th of March 2026. Thank you very much, everybody.